Ladies and gentlemen, we aim to begin the conference in 5 minutes from now. We request you all to kindly be seated and please switch your phones to silent mode. You may bring your tea and coffee cups to your table. We aim to begin in next 5 minutes. Thank you. Again, request all to kindly be seated. Please take your seats, make yourself comfortable as we are now starting the conference. Kindly switch your phones to silent mode. Ladies and gentlemen, we'll begin today's conference on an auspicious note. May I request our esteemed dignitaries to kindly proceed for the lamp lighting ceremony. Mr. Rajesh Bhushan, Professor Rakesh Yadav, Dr. Ripen Gupta, Mr. Anil Rajput, Dr. Sanjeev Singh, to kindly proceed for the lamp lighting ceremony, to kindly light the ceremonial lamp and officially inaugurate the Illness to Wellness Conference. Requesting Sri Bhushan sir to please light the lamp. Ladies and gentlemen, a round of applause as we now light the ceremonial lamp. Thank you very much, dignitaries. You may now please come together for a group photograph. Ladies and gentlemen, with this we officially inaugurate the Illness to Wellness Conference on Transforming Hypertension Care, Prevention to Wellness, being organized on the occasion of the forthcoming World Hypertension Day 2026. And with this, we'll request our esteemed dignitaries to kindly grace the stage with their presence. Please join me in welcoming on stage Mr. Rajesh Bhushan, former Secretary, Ministry of Health and Family Welfare, Government of India, and Chairperson, Governing Council, Illness to Wellness Foundation. Can we give him a more energetic round of applause? A very warm welcome to you, sir. We also welcome on stage Professor Rakesh Yadav, cardiologist and head Department of Emergency Medicine, All India Institute of Medical Sciences, New Delhi. A hearty welcome to you, sir. We now welcome Dr. Ripen Gupta, Vice Chairman and Unit Head Cardiology, Max Smart Super Speciality Hospital, Saket. A very warm welcome to you, sir. We now welcome Mr. Anil Rajput, Chairperson, Advisory Council, Illness to Wellness Foundation. A very warm welcome to you, sir. We also welcome Dr. Sanjeev Singh, Chairperson, FICCI Medical Education Task Force and Medical Director, Amrita Institute of Medical Sciences and Research Center, Faridabad, and Chief Medical Superintendent, Amrita School of Medicine, Kochi. We once again extend a very warm and hearty welcome to all our esteemed and distinguished dignitaries. Thank you very much for joining us for the inaugural session and sparing your precious time for us. And now, as a token of appreciation and as a gesture of warmth, we'll now present floral bouquets to our distinguished dignitaries on stage. May I request Mr. Anil Rajput to please present a floral bouquet to Mr. Rajesh Bhushan. Can we all once again welcome? Sir, thank you very much for gracing us with your benign presence. We now present a floral bouquet to Professor Rakesh Yadav. Mr. Rajput to kindly do the honors and present it to Professor Rakesh Yadav. We now present it to Dr. Ripen Gupta. Kindly keep the applause going. And now we warmly welcome Dr. Sanjeev Singh. Thank you very much, dignitaries. Your presence today brings great strength and inspiration to this conference, this very relevant and impactful conference. being organized by Illness to Wellness Foundation. And now to formally welcome the gathering, may I invite on the dais Mr. Anil Rajput to kindly deliver the welcome address. Can we please warmly welcome him on the dais, Chairperson, Advisory Council, Illness to Wellness Foundation.
Mr. Rajesh Bhushan, former Secretary, Ministry of Health and Family Welfare, Government of India, and Chairperson, Governing Council, Illness to Wellness Foundation. Professor Rakesh Yadav, cardiologist and Head, Department of Emergency Medicine, All India Institute of Medical Sciences, New Delhi. Dr. Ripin Gupta, Vice Chair and Unit Head, Cardiology, Max Smart Super Specialty Hospital, Saket. Dr. Sanjeev Singh, Chairperson, FICCI Medical Education Task Force and Medical Director, Amrita Institute of Medical Sciences and Research Center. Distinguished guests, friends from media, ladies and gentlemen, good morning. It gives me immense pleasure to welcome you all to this conference on Transforming Hypertension Care, Prevention to Wellness. World Hypertension Day is observed every year on 17th May. It was initiated by the World Hypertension League to raise awareness about hypertension and promote prevention, early diagnosis, and effective management of high blood pressure. It serves as a reminder that one of the world's most widespread health conditions is also amongst the most preventable. Hypertension is often referred to as the silent killer because it develops quietly without visible symptoms, yet can lead to severe health complications if left unchecked. Globally, nearly 1.2 billion adults between the age of 30 and 79 are living with hypertension, with almost 2/3 residing in low and middle income countries. In India alone, an estimated 220 million people are affected, and the numbers continue to rise. Even more concerning is the fact that a large number of individuals remain undiagnosed, untreated, or inadequately managed. Much of this challenge is rooted in the lifestyles that modern systems and work cultures have created. For decades, progress has largely been measured through productivity, speed, and economic output. We were chatting up together when we were sitting, and how our society has changed over the years in our own life. When we were younger, the pace of activity was very different. The news used to travel after 24 hours through a newspaper, and today we get news nanosecond. And we don't have time to think, we don't have time to even look at what is happening around us, because the WhatsApp today take bulk of our attention and time. Many a times you will find that you picked up a phone to make some important communication, and you already see a WhatsApp message already lying in your inbox, and you begin to see that. When you see that, you forget why you picked up the phone. And this is the distraction that we are living in today. This is the kind of stressful life we have. So While these have undoubtedly improved our lives in many ways, they have also created lifestyles marked by long working hours, constant connectivity, sedentary habits, poor sleep, and rising stress. In many ways, modern life has moved faster than human well being has been able to keep pace with. In fact, if your phone is not around you for a few seconds, you get very disturbed and restless. And this is actually adding to your stressful life. This is one of the symptoms. In many countries today, they are saying that you will not be allowed to carry your phone along with you in the school. And many parents are going and having various kind of arguments with the principals because children are putting pressure because they are getting into depression. Now, this is the kind of stress we are having across the world, and India is not immune to it. If you look back at earlier societies, life moved at a more natural rhythm. Work existed, but there was a greater flexibility in how people organized their lives. There was more time for physical movement, social interactions, leisure, and mental pause. Communities were stronger and routines were less hurried. Today, with increasingly demanding lifestyles, people are left with little time to prioritize their own health. Many people find themselves with less time for exercise, family, or even adequate rest. Because many a times I have heard that people, while they are sleeping in the night, they will be looking for their phone as soon as they have a blink of awakening. So, this is the kind of life the current generation is living. The result is growing imbalance between professional demands, personal well-being. Increasing the risk of lifestyle disorder such as hypertension. Another emerging concern is growing anxiety surrounding artificial intelligence. This is the most hot topic that is going around because people are feeling stress across the world. Many employees are feeling that AI may replace their jobs, reduce human relevance in the workplace. Studies are now pointing to a phenomena described as an AI replacement dysfunction associated with stress, insomnia, burnout, and anxiety, all of which can further aggravate hypertension and other lifestyle disorders. However, I firmly believe that we must look at the AI revolution differently. Artificial intelligence should not only be viewed through the lens of automation or job displacement, but also as an opportunity to improve the quality of human life. We are all talking about work-life balance, and here is artificial intelligence can provide you work-life balance if we view it in that context. A recent report by Boston Consulting Group highlighted that AI is likely to reshape more jobs than it replaces. By reducing repetitive workloads and improving efficiency, AI has the potential to give people something increasingly scarce in the modern life, and that is time. Time for exercise, time for family, time for reflection, time for leisure, and time for meaningful work instead of mechanical work. In that sense, AI, if deployed responsibly, can become a powerful enabler for healthier and more balanced living. The true promise of innovation lies not only in making industry smarter, but in making human lives healthier and happier. At the same time, transforming hypertension care requires collective action from governments, healthcare providers, employers, educators, and communities. Workplaces must encourage healthier routines. Preventive screening must become more accessible. Public awareness around nutrition, exercise, and stress management must become stronger and more sustained. Such an approach is particularly relevant for India, where our civilizational ethos have always emphasized balance between body and mind, work and rest, material progress and inner well-being. In many ways, the modern wellness movement is rediscovering principles long embedded in our traditions. The Illness to Wellness Foundation, since its inception in 2014, has worked with a clear purpose to promote holistic well-being through health education, sustainable hygiene practices, lifestyle changes, and by blending ancient wisdom with modern technology. Through our health camps and outreach initiatives, we have observed that many people remain unaware that they are living with hypertension. Along with awareness generation, we encourage timely consultation and guidance from healthcare experts so that prevention and early intervention become a way of life. As we observe World Hypertension Day, let us recognize that the fight against hypertension is not only about lowering blood pressure numbers. It is about building healthier lifestyles, healthier workplaces, and ultimately a healthier society. In conclusion, let me leave you with a guiding framework for a collective approach, which I call impact. I integrate prevention into everyday life. M, mainstream wellness across workplaces and communities. P, prioritize physical and mental well-being. A, adopt technology responsibly for healthier living. C, create awareness through collective action. T, transform healthcare from treatment-centric to people-centric. Friends, today's conference offers a vital platform to share experiences, exchange ideas, and learn from experts of eminent doctors and practitioners. I'm confident that the discussions ahead will inform, inspire, and motivate action at individual, community, and policy levels. Let us engage actively and leave with renewed commitment towards creating a future where prevention becomes the first line of healthcare and wellness becomes a shared national priority. I have a request with everybody who is sitting here. I would like to share the takeaways that you take from today's deliberation with at least 100 people close to you. This small effort by you can create a much larger ripple of awareness and will be meaningful contribution towards building a healthier India. I once again welcome you all and wish you a productive and enriching session. Thank you and Jai Hind.
Thank you very much, sir, for the warm welcome and setting the perfect context for the conference today. And now it is my privilege to invite on the dais Dr. Ripen Gupta, Vice Chairman and Unit Head Cardiology, Max Smart Super Specialty Hospital, Saket, for this special address. Can we please welcome him on the dais?
you, everyone. Basically, I'll be just discussing on what already has been talked. Hypertension is a very, very common problem, and everyone thinks that he is not having high blood pressure. So it is a silent killer, has no symptoms till it causes complications. We all know, but nobody is willing to accept that he is having high blood pressure. Patients will come to my OPD, BP readings are high. We'll tell them to get a repeat readings done. They'll say it is just because I was under stress, and he will not get it checked. And once he has a complication, then he will understand the implications. We recently lost a 44 years worker in our hospital. He was having high blood pressure but was careless, and he had an intraventricular bleed and died at 44 years of age. So this is the implication that you can have a young death, which could have been easily prevented, was because of carelessness. So hypertension as such is a very big problem. It has a prevalence of around 35.5%. 1 in 4 adults are affected. As already told, around 20 crore people are hypertensives. And it remains the most important cause for premature mortality in Indian subcontinent. So this is very easy to detect, does not require very high-tech instruments. BP instruments are, automatic instruments are there at everyone's home. It can be easily checked, and treatment can be easily taken. The medicines are not expensive. But somehow we have some clinical and patient inertia, so the treatment is not given to all. In fact, if you see the recent prevalence survey, urban male it was 38.7, urban women 32, but if your age is more than 60, it crosses 66%. So we have to remember that hypertension increases with age. As you age, the incidence of hypertension will become more, and complications of stroke and all will become more. But despite everyone knowing about this problem, so we don't have to teach anyone that what is high blood pressure, the awareness is still lacking, especially in the rural area. Only 50% are aware that they are hypertensive. Out of the 100 patients, only 35 are right now taking treatment. And the BP control, when we follow the guidelines, they say that your BP is controlled, is only in 15%. So a very minority of patients are having their blood pressure under control, and this is a major issue, because if I am taking a BP medicine and I'm not taking, my BP is not controlled, the complication will still happen. So this happens to a lot of my patients. I give them a medicine, the BP is on the higher side when they come to my OPD, and they have a resistance to increase the medicine because they feel that it's a lifelong medicine. If I increase it now, then after 5 years, you will say you will increase it again. So they will not increase the medicine. They will be suboptimally treated, and then they will have complications, which I'll be discussing in the next few slides. So this is a very, very important thing. We have to work on the psychology of the patient, make him take the treatment, tell him the importance of numbers, that at least the numbers are controlled, then the complications will also be controlled in the future. So hypertension is a silent killer. It doesn't shout its arrival. It whispers in the form of damaged organs. So this is what we should all remember. And the common reasons of hypertension in India is, number one, salt intake. You see, my theory is that we are in a tropical country. We were living in rural, semi-rural areas 100 years back. There was no AC, no fans. And at that time, we were working in the fields. We need this extra salt for survival. So all these pickles, papads, they were, in fact, our survival tools. But now when we are living in an AC environment, we have fans, we have better living conditions, our food habit has not changed. So we are now taking 10 grams of salt per day, which is double the WHO recommendation. And this has led to spurt of hypertension in the population. Similarly, more use of fast food that contains a lot of salt. So that is again contributing. So our younger generation is more attuned to this fast food stuff. So this also is a very important factor for, I'm seeing young hypertensives, 16-year, 15-year boys having 160 by 100 BP. So this is the reason for that. And second is sedentary habits, lack of exercise. We didn't used to have this Netflix and all these channels, TV channels, no mobile. So we all used to come home and then go out for playing with our friends and all. Right now, all they play is on the video, on the phone and all. So that lack of exercise is also playing a part. And in lack of space also is a constraint in some places. But this is also a very important factor for rise of blood pressure in Indian subcontinent. And psychosocial stress, has already alluded to in the last, sir has already alluded to this, and this is a very, very important factor. So all these three factors are driving hypertension in India. And the first line of defense is prevention. Rather than we treat it with medicines, we should prevent hypertension. And the best way is to start a early screening, that is opportunistic BP checkup at any person who comes to a doctor's visit 18 year plus. So whenever he comes, whether he comes with a fever, cough, cold, or pain in back, or pain in the abdomen, he should have a BP checkup done. So at least he's aware that his BP is on the higher side. So let's say he comes 2 or 3 times to the doctor, and every time he's told that his BP is high, at least it will strike in his mind, and then he may think of taking treatment. Annual screening for all citizens above 30 years of age is very important, and high-risk groups like diabetics, obese patients, they should have at least twice a yearly BP checkup. So I think this protocol should be followed by everyone. A lot of time I see that a patient comes to a GP and he has let's say a fever problem or something, and his BP is not checked. So that I see in half the prescriptions which come to me. So I think we should make it a point that any patient who comes to a doctor should have at least a BP checkup done. It can be done by even the sister or assistant who is sitting outside using automatic instrument. So that doesn't take much time, but at least gives a hint on who is hypertensive, or even if the person is hypertensive, is he controlling his BP with medications or not. So as I already told, sodium trap in Indian diet is very important. We should shift to potassium-rich salt. So one option is to use more of rock salt, but the only problem with that is that it is non-iodized. So what I see is that a lot of my patients who take rock salt, which is non-iodized, they end up with a subclinical hypothyroidism. Their TSH levels go up. So we should prefer rock salt, which is potassium-rich, but it should be iodized. So that is very important. And we can adopt our diet. The DASH diet is one which helps in bringing the BP down. And in Indian subcontinent, we can, like grains, we use more of maida. Even the wheat which we get, this flour which we get from all these big companies is like a maida only. And white rice. So these are not good for our health. We should use more of millets like bajra, ragi, and brown rice. Proteins, rather than taking red meat or fried paneer, because paneer is good, but it contains a lot of fat also, and in India we fry it also on top of it. So we can have grilled paneer. We can have even low-fat, high-protein paneer, which is available in Indian subcontinent now. Use more legumes, soya. So these are all healthy proteins which we can take. Vegetables, instead of having fried vegetables, we can have steamed or sauteed greens. And snacks, instead of namkeens and samosas, which are very fond of, we can have roasted makanas or unsalted nuts, which are good. So we can change our diet a little bit. It will not be tasteless, but it will be healthy diet. And at least 150 minutes per week of brisk walking or exercise is recommended. And at least twice a week resistance training is very, very important, because it helps in improving insulin sensitivity. And India is the diabetic capital of the world, so we should remember that. So resistance training is very important. So a lot of my patients, they will go for walk and they are very happy. They'll say, I'm doing 10,000 steps, 20,000 steps per day. But when I ask them, are you doing resistance training? 90% say no. And they face a problem when they become 70 plus or 80 plus, because then they have a lot of health issues because their protein mass is not there. So muscle mass is not there, proteins are low, and then when they become sick, they become very sick, and that is very important. Reducing the desk time is very important. We should not sit on the desk for 8 hours straight. We should move around every half an hour for 5 minutes. So that is very important for our, at least all these lifestyle managements will have an impact. In fact, this is equivalent to taking 1 tablet of antihypertensive medication. So if we follow lifestyle modification and the patient requires just single pill of blood pressure medicine, it can be prevented just by lifestyle change. And a lot of patients will not even develop hypertension if they follow this from the beginning. When we talk of blood pressure, our focus is on the numbers, that we want to bring the numbers down, we want to bring it in a manageable level, but now the focus has shifted to organ protection, because numbers are important, but we should also look what are the damage this blood pressure has caused to the various organs in the body. Like for heart, it can cause thickening of the heart muscle, which is known as left ventricular hypertrophy. In the kidneys, it can cause damage and lead to leakage of protein in the kidneys. And the arteries can become more stiff, which promotes more stroke in the elderly patients. So if we treat BP well and bring the numbers down, we can lead to LVH regression, proteinuria will become less, arterioles become more supple, so less stroke chances are there. In fact, hypertension is the #1 cause of stroke in India. So if we can control this, we can decrease the number of strokes. We can decrease the number of heart failures, because one of the important factor leading to heart failure nowadays is Heart failure means preserved ejection fraction, where the heart function is normal, but the patient is still breathless. This is seen mostly with diabetic patients or with hypertensive patients who are not well controlled. So if we do that, these heart failure patients can be well managed. Kidney problems can be obviated. In fact, 40% of dialysis patients are having hypertensive nephropathy. So if we control blood pressure, we can decrease the number of dialysis patients. So early detection and aggressive control is very, very important. And then a new concept has come in, that is a single pill combination therapy, that if a patient is given from start a combination of two drugs in one pill, the advantage is that it improves the clinical results. The BP is well under control in around 70-80% of the patients, and the adherence of the patient becomes better. If I am giving two pills to the patient, one in the morning, one in the evening, or 3 tablets, he may miss one of the tablets, or he will feel that he is taking too many tablets, he leave it altogether. But if we give a single pill, which contains two medicines, number one, the dosage is more, so BP control is better, and secondly, the adherence is better. So this is a newer concept which is promoted world over, that we should use single pill combinations. In India, we have been using this for a long time, but now even the world authorities are endorsing this as a very important tool for BP management. So in India, the challenge for blood pressure control is, number one, the symptomless nature. Patient says, I'm okay, why should I take a medicine? And when we tell them that medicine will continue for life, in most of the cases, they are very skeptical. And cost is a concern, because it is expensive therapy when we take it lifelong, because the patient may be taking other medications also. Forgetfulness is very important, because patient has no symptoms, he has no pain, nothing to remind him to take the tablet, he can leave it after some time. And the myth that it is a lifelong medicine, and now he has a disease for which he has to take the medicine till he dies. So this is a very, very important factor. Now, Indian government has started a India Hypertensive Control Initiative, where they are providing free medicines at primary centers for hypertension patients. So efforts are being made to obviate using single pill combinations, providing free medications. So this is what is helping us in having a better control over this problem. And now coming to the wellness shift. Now, use of Indian therapies like yoga, meditation is very, very important. It has been proven in a number of studies that it lowers the blood pressure and leads to a better long-term BP control. Because once we do regular yoga meditation, there is a reduction in cortisol level, improvement in parasympathetic tone, and enhanced vascular function. So all these things lead to a better blood pressure control in our patients. So we should promote this. Just a patient comes to our OPD, we should not just write a medicine. We should tell him that do lifestyle modification, do exercise, do yoga, do meditation. So all this will be important. And sleep, has already been alluded to, is very important, because if the circadian rhythm of sleep is disturbed, it leads to a non-dipping BP profile on 24 ambulatory BP monitoring, and this is a sign for future complications. Or also, sleep apnea is a very important underdiagnosed problem which we see in Indian patients, especially obese patients with short neck. It is very common, and that can lead to resistant hypertension. So in those patients, we should do a sleep study and manage those patients accordingly. Good sleep is again an important factor in controlling blood pressure. The use of AI in blood pressure control is important, because we can use, even now devices are coming in where BP can be checked with the simple smartwatch, or even the Apple iPhone. I think they are bringing in some app where the BP can be checked just by putting your finger on it. So all these things are making the things easy. We can have apps can be made to make a patient remember the medications. They will give a reminder to the patient that you have not taken the medicine. And patient can be linked to the doctor. So if he has a problem, he can send the message to the doctor, and he can tell the patient, okay, let's say my BP is low, should I miss the dose? The doctor can say, no, take, because a lot of time I get this now on WhatsApp. A patient has a BP fluctuation, he'll send a message to me that what should I do? And I'll guide him. And after 10-15 times, he'll understand, okay, this is how I have to manage the BP. Then the messages will not come. Same thing can be done on a physician remote dashboards also. So AI is going to help in making our BP control better, because it's a chronic disease and we don't want the patient to come to our OPD again and again. So if we can manage this patient remotely, it is very important. And Indian government has now started telemedicine for this, because they're connecting the village health centers with cities like Delhi, Faridabad, and where they can get guidance on the management. And there's a 90% coverage is there for this till 2025, and they are planning at 100% coverage by next year. And in 2023 World Hypertension Day, there was a vision, 75-25 vision from Indian government, where they have planned that 75 million people should be on hypertension and diabetes treatment by 2025, and they have achieved 90% of the target. And they are aiming for a 25% reduction in prevalence of these diseases due to early detection. And Indian Hypertension Control Initiative started in 2017, and now it is basically a pan-India coverage with centralized digital registry. So government is making efforts, but as a public, we also have to bring this into the mainstream. We should all be promoting hypertension as a very serious disease to be taken seriously, where we have to manage the patient for a long term. And we should tell the complications to the patient upfront, that these are the complications which can happen if he is not careful in his treatment. So community-led wellness, where even nurses, ASHA workers, they can do a BP screening and follow-up. Drug supply, which can be made free in primary centers or sub-centers, and public awareness. These are all community-led wellness measures which can help in a better BP control. And if we just look at detection and treatment, we can reduce the risk of stroke and heart failure by around 65%. So this is very important, that hypertension complications can be prevented. It's not like that we just bring the numbers down and BP is controlled. It has a downstream benefit that all the complications we can prevent by around 70%. 2/3 of the patients will be benefited. So this is very important. So the key action points for 2026 should be mandate BP checkup for all adults age 18 plus, follow simple treatment algorithms using single pill combinations, prescribe yoga and low salt as seriously as medicines, and we should use digital health apps for patient engagement, and support the 75-25 initiative, which is promoted by Government of India. So thank you for your attention. So question and answers, sir, we should take at the end, or we can have now? And
Thank you very much, Dr. Gupta, for your valuable insights. And now may I respectfully invite Professor Rakesh Yadav, cardiologist and head department of emergency medicine, AIIMS, to deliver the special address. Can you please welcome him on the dais?
Thank you. Respected Rajesh Bhushan ji was a former secretary, and we medical fraternity always thankful for him for making such good policies in Government of India for hypertension, for preventive care. So we are thankful to you, sir, for Anil ji, Dr. Ripen, Dr. Sanjeev. What I am going to discuss in next 10 minutes is not medical lecture on hypertension, because everybody knows, everybody has ChatGPT, AI Cloud, WhatsApp. And if you want to know about hypertension, you can know very well. The biggest problem in this country, we know about Bollywood. Everybody knows about what is happening in Bollywood. Everybody knows what is happening in Pollywood. Pollywood, I say, for political circle. We all know about neighborhood, but we never want to know about our health. You are hypertensive. If I say what medicine you are taking, doctor sahab peeli wali dawa lete hain. Still nobody, even it is in a light circle, very intelligent people, they say doctor sahab wo 10 milligram ki dawa lete hain, but they will never say me, I am taking, tell me certain 40 milligram. That is the biggest problem in this country, why we are not able to tackle hypertension load. And as you know, in adult population, 50% are hypertensive. More than 80 years, 80% are hypertensive. And what the present situation is, there is a survey in a school, less than 12 class. We find obesity in 25% of cases. And among these obese, 20% are pre-hypertensive. This is 17, 18 years old children. Second important thing, the myth is, blood pressure to अमीरों की बीमारी है. Absolutely wrong. I used to go do a camp in villages just measuring our blood pressure and sugar. I am surprised to know that the incidence, the prevalence of hypertension in a rural population is not less than urban population. And even they don't know their blood pressure of 180 by 100 from last 10 years. If they don't know, they will not take medicine. Third important thing, why we are not able to control. If you go to a doctor, you are a hypertensive, the doctor will prescribe the medicine which is costliest medicine. They will say it has a least side effect. It's a very new drugs. Give amlodipine costing 50 pies. 90% blood pressure will be controlled. There is some empirical indication, for this hypertensive, ye dawa chahiye. That is an entirely different issue. But I always say our medical fraternity, please don't give costly medicine for hypertension care because it is a lifelong. And the majority of the dropout of hypertension treatment is the cost. They will write one multivitamin, one calcium, and hypertensive medicine which is costing 2 rupees, but the multivitamin and calcium are costing 50 rupees. A poor patient doesn't know which is an important drug. So if you detect hypertension, I say always give a cheap medicine. There's no harm, no much side effect. It is only our confusion that this drug has least side effect. This drug doesn't cause pedal edema, which is in 3% cases of amlodipine. Stop in 3%. But giving 20 rupees tablet per day versus 1 rupees tablet per se will definitely improve the hypertension control in this country. Third important thing, I say 99% doctors doesn't know how to measure blood pressure. I am bluntly talking about this. How to measure a blood pressure is very important. मेरे पास डॉक्टर साहब आज सुबह सर में दर्द था, ब्लड प्रेशर नापा 160-100 था, मैं तो हाइपरटेंसिव हो गया, अब दवा शुरू गया, somebody has started the medication. I say आपका ब्लड प्रेशर दिन में 30 मिलीमीटर चेंज होना ही होना सिस्टोलिक. आप एंजाइटी में आएंगे 30 मिलीमीटर बढ़ जाएगा, आप कूल रहेंगे 30 मिलीमीटर कम हो जाएगा, आपका डायस्टोलिक 10 to 15 मिलीमीटर दिन में चेंज होगा. अगर नहीं होता है तो आपके मरने की संभावना ज़्यादा है. इसका मतलब आपका ऑटोनोमस डिसफंक्शन हो चुका है. तो ब्लड प्रेशर कैसे नापिए, दैट इज द मोस्ट इंपॉर्टेंट मैसेज, एंड आई थिंक दिस मैसेज शुड बी गॉन फ्रॉम यू टू योर रिलेटिव्स टू योर फ्रेंड्स. हमेशा यू हैव नॉट टेकन टी, कॉफी, स्मोकिंग इन लास्ट 20 minutes. You are relaxed for 10 minutes. You have no pain abdomen, no headache. You are not in anxiety. You have not taken food for last 2 hours. You have slept properly. Measure in the morning, just relax, take deep breathing for 3 or 4 minutes, measure your blood pressure with the automatic machine. Don't see the first reading. Just take a 2 or 3 more breathing, take a second reading, and that is your blood pressure. थर्ड मिसकन्फ्यूजन, ये ऑटोमेटिक मशीन गलत आती है डॉक्टर साहब. मैं मैनुअल नापता हूँ तो ये आती है, इससे नापता हूँ तो ये आती है, बिकॉज यू डोंट नो हाउ टू टेक ब्लड प्रेशर फ्रॉम दीज मशीन्स. थर्ड इंपॉर्टेंट थिंग, डॉक्टर साहब मेरे ब्लड प्रेशर बढ़ा हुआ इसलिए मेरे सर में दर्द हो रहा है. आई थिंक इट्स अ वेरी कॉमन कंप्लेंट. बिलीव मी, माइल्ड हाइपरटेंशन कैन नेवर कॉज हेडेक. हेडेक मीन्स यू हैव ब्लड, आपका सेरेब्रल एडिमा हो गया है. This is all myth in knowing the blood pressure treatment. Because of your headache, your blood pressure is slightly raised. Treat your headache, not a blood pressure. That is the important thing. Third myth which is being circulated in this country, and I have seen a lot of things, salt कम कर दो. Salt कम सिर्फ उन लोगों में कराइए जो AC में रहते हैं, जो sweat नहीं करते हैं. हमारे यहाँ जो हम ट्रेनिंग देते हैं, we train senior resident की salt कम कर दो. And we AIIMS cater only the poor population. If I see how many patients coming to the AIMS OPD has AC assessment, I say less than 0.5%. They don't have AC, they sweat a lot. Especially in the summer, you say restrict your salt and they will end hyponatremia. And it is a very common phenomenon, especially when you treat patients from Bihar, from Bengal, from Assam, which has humid environment. So beware of advising something if you don't know the circumstances of the patient. One day I told to a patient, "Sir, walk क्या करो?" कहा, "साहब साधु महात्मा तो कभी वॉक नहीं करते थे, फिर भी 150 साल कैसे जिंदा रहते थे? वो तो तपस्या 2 साल बैठे हुए करते थे." So you have to have an argument. You have to have every explanation. Walking means you have to burn your calories. Whether you stretch, whether do yoga or do a walking. So if Hamare sadhu, they used to do yoga. It is equivalent to walking. So don't say only walking if you are doing yoga, if you are doing stretching, it is equal effect on body. The most important thing in obesity. Believe me, the obesity is the founder of all illnesses. If you reduce your weight by 10 kg, you will reduce your systolic blood pressure by 10 to 15 millimeter and diastolic by 5 to 10. So if you reduce your obesity, the blood pressure will definitely decrease. Next myth is, I always say my 50% of hypertensive patients are on mild antidepressant or taking sleeping pills. And their blood pressure requirement pills comes by 1/4. I always ask person, आपको blood pressure है, नींद आती है? 90% will say, डॉक्टर साहब नींद बहुत डिस्टर्ब है. And they don't want to take pills. They say आदत पड़ जाएगी. हमने कहा आपको खाने की आदत है तो खाना क्यों बंद कर दीजिए इसकी भी आदत. A good sleep is very, very important. Start with pills. If you have a good sleep, then morning you can do yoga. If you have a bad sleep, you can never do yoga in the morning because you are disturbed. So your sleep is very, very important. Always remember, if you have a disturbed sleep, you are hypertensive, try to treat your sleep. You can help you out by yoga, by anything, but what I always say, if you cannot, take help of medicine for a proper sleep. The myth again come for hypertension, उबला खाना शुरू कर दो. ये बहुत कॉमन है यार. आदमी कहता सब इफ आई कैन नॉट टेक अ बॉइल्ड, इसका मतलब छोड़ दो, ब्लड प्रेशर रहने दो, डायबिटीज रहने दो, मैं तो मरना ही मरना है लेकिन मैं खा पी के मरूंगा. दिस इज अ वेरी कॉमन कंसेप्ट. आई ऑलवेज से उबला खाना जहर है. You required fat in your body. You required essential fatty acid in your body. It makes all your hormones. So you required a fat in your body. But you should take a good fat. Take unsaturated fat. Don't take saturated fat. Don't take trans fatty acid. बहुत बार ऐसा होता है कि boiled के चक्कर में you start developing something else. Restrict your calories. That is an important message. Take good carbohydrate. Take good fat. Take reasonable salt. That is also a very, very important thing. Take reasonable salt according to your culture. Last important thing is why the monitoring is important. In my drawing room, I always keep one BP instrument. And I'm a social person, तो हमारे पास बहुत friend आते हैं. अरे BP instrument लगा, चलो आज BP नाप लेते हैं. They are hypertensive. They are taking medicine. हमने कहा तुमने अपना BP कब नापा था? पता नहीं, 2-3 महीने हो गए होंगे. नापते तो आता है 160-100, फिर उनको एंजाइटी शुरू होती है. हमने कहा यू हैव अ बीपी इंस्ट्रूमेंट एट योर होम. कहाँ है? क्यों नहीं मेजर करते हो? व्हाई यू डोंट मेजर? दैट इज द बिगेस्ट प्रॉब्लम विथ अस. वी नेवर मॉनिटर आवर ब्लड प्रेशर. सो द मैसेज इज, इफ यू आर हाइपरटेंसिव, प्लीज बाय अ बीपी मशीन. Please measure it regularly and encourage your relative, your friend to measure it regularly. That is the most important thing when you are having hypertension and you want to treat yourself. And the last thing is, the blood pressure is really a silent killer. It is really, really a silent killer. Uncontrolled hypertension can lead to every illness in your body, including brain, heart, kidney. Everything can be damaged by the hypertension. So it is really, really a silent killer. So please, and I think illness to wellness, I request them to spread this knowledge to rural population. Sir, it is equal to the urban population. And they are not at all getting any information about hypertension, even not having a screening. So the government that every patient should be screened at least for 2 diseases, blood pressure and sugar, will definitely decrease the mortality in this country by these 2 killer diseases. Thank you very much for your kind attention.
Thank you very much, Professor Yadav, for not only sharing your insightful perspective with us, but also breaking some myths along the way. And now, ladies and gentlemen, we move to the keynote address. It is my honor to invite on the dais Mr. Rajesh Bhushan, former Secretary, Ministry of Health and Family Welfare, Government of India, and Chairperson, Governing Council, Illness to Wellness Foundation, May we have a huge round of applause for him, please.
Shri Anil Rajput, Professor Rakesh Yadav from AIMS, Dr. Ripin Gupta from Max Super Speciality Hospital, Dr. Sanjeev Singh from Amrita Institute, ladies and gentlemen. It's indeed a pleasure to be here. I would begin from where Dr. Yadav left. The problem or the issue of hypertension is as prevalent in our rural areas as in the urban areas. But since we all reside in metropolitan cities, we look at this issue of hypertension from a urban point of view. So we must expel this thought from our minds that this is a urban-centric problem. It is not. And since it is not, and since we are a country of more than 140 crore people, and since a significant proportion of our population is in rural areas, therefore what becomes important is early detection. Until and unless you have early detection, you would not have early diagnosis and early treatment, and therefore the problem would keep on persisting. And this is a problem which has a direct impact on the national GDP. If we look at the overall non-communicable diseases, the estimates are that every year we lose anywhere from 2% to 4% of our annual GDP because of non-communicable diseases, which lead to avoidable deaths. And within this spectrum of NCDs, the hypertension and multiple other ailments which are triggered by hypertension play a big role. So therefore, early detection. In this context, in 2018, Government of India decided that at the lowest level, which is the level of the health sub-centers, Dr. Gupta referred to the Ayushman Arogya Mandirs. They were earlier called health and wellness centers, now they are called Ayushman Arogya Mandirs. In rural areas, they roughly cater to a population of 5,000 people. And on top of them, the primary health centers that cater to a population of roughly 30,000 odd people. At that level, Government of India decided in 2018 that they would do a population level screening. किसको hypertension है, किसका blood pressure बढ़ा हुआ है, किसका नहीं बढ़ा हुआ है. And this exercise has been going on from 2018 till date and would continue. However, there is one catch in this population level screening. It's done for people who are 25 years or more than 25 years of age. So how does this exercise work? मैं 25 साल या उससे ऊपर हूँ, मैं गांव में रहता हूँ. The local ASHA, who's a accredited social health worker, she would come to me and say कि बगल में health sub center है या PHC है, why don't you go and get your blood pressure checked? My blood pressure is checked and I am told that I am hypertensive in a hypothetical scenario. Then I say, अब मैं क्या करूं? आपने मुझे बता तो दिया that you are hypertensive. So I am told that you are being referred to a secondary healthcare facility, which could be a sub-district hospital or a district hospital, because that is where the specialist doctor would be available. I may go there after referral, I may not go there. Even if in a good scenario, ideal scenario, I go to this secondary or tertiary healthcare facility in a rural or semi-urban setup, I would get prescribed certain medicines. There is no way of monitoring whether I am taking those medicines or I am not taking those medicines. There's no way of monitoring whether those medicines are available, because most of these medicines are supposed to be provided free of cost in these facilities. So that is the challenge that we have to try to address. One, that our screening, population level screening or detection, which is a follow-up of that screening, is universal, सबके लिए उपलब्ध हो. Second, once that screening has been done, we must use information technology, आजकल ऐसे बड़े tools हैं, to see that this cycle of screening, diagnosis, treatment and adherence to treatment, ये हो रहा है कि नहीं हो रहा है? Because otherwise screening becomes irrelevant. आप करोड़ों लोगों की स्क्रीनिंग करके उनको बताएं कि आप हाइपरटेंसिव हैं, this is neither here nor there until and unless they are brought under treatment and someone monitors that adherence to that treatment is being done. So therefore, going ahead, both for the public sector as well as for private sector, because we have doctors from private sector here, the challenge is to ensure early detection, early treatment, and adherence to the treatment regimen. So that's one part of the challenge. The second part of the challenge is, what do we do about the rapidly changing lifestyle and rapidly changing food habits? When I look at this issue, I can say that the food that my parents or my grandparents, they are younger kids here, so probably they won't be able to use this analogy because their parents probably were using the same kind of food that they eat. But my parents and my grandparents were actually eating coarse grains, at least in the rural areas. Now they are not being grown, so obviously they are not being eaten. They were far better source of protein as well as carbohydrates than what we eat today, the food grains that we eat today. So a bigger challenge is to ensure that the food habits, and there are people who are doing it. For example, within the government setup, I know ICMR's institution called National Institute of Nutrition in Mysore has said that this is how an ideal food pyramid for an Indian should look like. Lekin how many people know this? Has it been disseminated, not disseminated? What are we doing as a community with domain knowledge? Dr. Yadav has domain knowledge, Dr. Gupta has domain knowledge, Dr. Singh has domain knowledge, to disseminate it in the community. Because of this increasingly reducing community connect of tertiary healthcare facilities, हम उन्हीं को देखते हैं जो हमारे पास आते हैं. या if we are a teaching hospital, medical college hospital, तो मेरा जो PSM वाला division होगा या community medicine वाला होगा, only they will be connecting with the community. Other doctors are not, because the kind of time management they have to do with their OPD, IPD, teaching responsibilities, it makes it difficult. But we will have to find a solution to this and increase this community connect of bigger tertiary healthcare hospitals where this domain knowledge about right lifestyle, right food habits is disseminated to the wider community, and that is where illness to wellness plays a big role. आप स्कूलों में ये आयोजन करते हैं, among different professional groups करते हैं, but we need more entities like illness and wellness to ensure that this actually makes an impact. And lastly, ये मैं हर बार कहता हूँ, जितनी बार I talk to Anil Rajput ji or to other colleagues, that as Indians, we have this huge deficiency of something that is known as health-seeking behavior. We do not seek specialized advice of doctors or clinicians. हम कहते हैं ठीक हो जाएगा जो भी है, गर्म पानी पी लो उससे ठीक हो जाएगा, अदरक वाली चाय पी लो उससे ठीक हो जाएगा, हमने तो अभी अचार खाया था इसलिए ब्लड प्रेशर बढ़ा हुआ है, हम नहीं खाएंगे तो ठीक हो जाएगा. So all this represents absence of health-seeking behavior. We must ensure that we care about our health and the health of our family members, our friends, our near and dear ones. Only then, in the community as a whole, this concept of health-seeking behavior would get ingrained, would get rooted, and then the doctors come into play. जब हम जाएंगे ही नहीं, लोगों से पूछेंगे ही नहीं, तो समस्या बनी रहेगी. So in the end, let me wish today's deliberations all success. And as Dr. Anil Rajput said, once you go back, if you share whatever you have learned from the domain knowledge experts who are sitting on the stage and who would come onto the stage in subsequent sessions with your family and friends, it will disseminate awareness about this subject in the community and would ensure that we are a more healthier nation. Thank you.
Thank you very much, sir, for your thought-provoking and remarkable keynote address. Ladies and gentlemen, we now arrive at the most distinguished segment of the inaugural session. Our chief guest is Shri Pratap Rao Jadavji, Honorable Union Minister of State Independent Charge, Ministry of Ayush, and Minister of State for Health and Family Welfare, Government of India, couldn't join us in person due to some unavoidable commitment, but he has sent a very special video message for all of us. We would request you all to kindly direct your attention towards the screen. Let's take a look.
नमस्कार. सर्वप्रथम मैं इलनेस टू वेलनेस फाउंडेशन को इस महत्वपूर्ण सम्मेलन में आमंत्रित करने के लिए धन्यवाद देता हूं. आज के समय की आवश्यकता है कि हम समुदाय को संवेदनशील बनाएं और हाइपरटेंशन के प्रति जागरूकता को मजबूत करें ताकि समय रहते रोकथाम और उपचार संभव हो सके. हाइपरटेंशन अब किसी एक आयु वर्ग तक सीमित नहीं रहा है. बदलती जीवन शैली और शारीरिक एवं मानसिक स्वास्थ्य पर कम ध्यान देने के कारण यह युवाओं में भी तेजी से बढ़ रहा है. इसे अक्सर साइलेंट किलर कहा जाता है क्योंकि यह बिना स्पष्ट लक्षणों के शरीर को प्रभावित करता है और हार्ट अटैक, स्ट्रोक, किडनी फेलियर तथा समय से पहले मृत्यु के जोखिम को बढ़ाता है. भारत सरकार नेशनल प्रोग्राम फॉर प्रिवेंशन एंड कंट्रोल ऑफ नॉन कम्युनिकेबल डिसीज के अंतर्गत हेल्थ एंड वेलनेस सेंटर के माध्यम से जनसंख्या आधारित स्क्रीनिंग, शीघ्र पहचान और प्रबंधन को सक्रिय रूप से बढ़ावा दे रही है. यह उत्साहजनक है कि इलनेस टू वेलनेस फाउंडेशन विशेष रूप से एनसीआर क्षेत्र में समुदाय आधारित स्क्रीनिंग और जागरूकता अभियानों के माध्यम से महत्वपूर्ण भूमिका निभा रही है और सरकार के प्रयास को सशक्त भी कर रही है. मैं इस कार्यक्रम में व्यक्तिगत रूप से उपस्थित होना चाहता था, लेकिन पूर्व निर्धारित दायित्वों के कारण शामिल नहीं हो पा रहा हूं. फिर भी मुझे विश्वास है कि सभी प्रतिभागी विशेषज्ञों के विचारों से लाभान्वित होंगे और इस संदेश को अपने अपने समुदाय तक पहुंचाएंगे. मैं एक बार फिर आयोजकों को, साझेदारों को, स्वास्थ्य सेवाओं को बढ़ावा देने और लोगों को बीमारी से पहले ही स्वस्थ रहने के लिए प्रेरित करने के उनके निरंतर प्रयासों के लिए बधाई देता हूं. आइए हम सभी मिलकर एक स्वस्थ, जागरूक और सक्रिय समाज के निर्माण की दिशा में कार्य करें. धन्यवाद. नमस्कार.
Thank you, Honorable Minister. We are truly grateful for your message. And now to deliver the concluding remarks, may I invite Dr. Sanjeev Singh, Chairperson FICCI Medical Education Task Force and Medical Director, AIM SRC Faridabad, and CMS Amrita School of Medicine, Kochi.
A very good morning, Rajesh Bhushan ji, Mr. Anil Rajput ji, Dr. Ripin, Dr. Rakesh, and all other dignitaries and the delegates. We have heard about the silent killer, and I'll start on a lighter note. There was this husband who was not feeling well, so wife took the husband to see a doctor, and doctor evaluated and said that do few things and your husband would be okay. Don't ask him, don't give him dirty looks for next 1 year and he will be okay. Don't Don't ask for any diamond and jewelry for next 1 year and he will be okay. Don't discuss your mother-in-law for next 1 year and he will be okay. Don't discuss sister-in-law, mother-in-law, daughter-in-law serial which comes at 9 p.m. with him and he will be okay. So both of them were coming back home. The husband asked, what did the doctor say? Wife said, you're not going to survive for long. And that is what we have heard. We will not survive for long if we don't follow the instructions which is so succinctly given by Anil Rajput ji, Dr. Ripin and Dr. Rakesh. Those prevention and clinical informations are extremely critical. And I think that should be the good takeaway from this particular meeting. I was looking at one of the videos which was circulated from Eco Insurance, which was done in Nasik. And we talked about inadequate treatment, unaware group of, and it's being silent. And they had used, there is a good indicator which is called as BMI, which we all know, height and weight which we measure, and then there is somewhere around 23 you need to be there. But a better indicator is a waist and a hip circumference. And they included all tailors in Nasik into this particular program, which was unheard of. They measure the hip, they measure the waist, and for male if it is 0.9 and above, or for female 0.85 and above, 0.85 and above, immediate trigger would be there for prevention activity. Such an important initiative, very simple for health literacy, and I think that is where we need to be more innovative. A lot of things have been already done, but can we think differently? Can we think something which is not been done so that masses can have an impact with an easy data which is coming because it's a silent killer? Mr. Rajesh Bhushan also talked about health seeking. We were organizing one program at FICCI and the Minister of State had come over and he said, आप लोग इतनी बड़ी बात तो कर रहे हो, लेकिन आदमी बीमार पड़ता है तो क्या करता है? उनके गांव में, वो आगरा को represent करते थे. First 2 days, he will not do anything. Second 2 days, he would look at grandmother's nushka. Next 2 days, he would look at first contact in the village area, which would be a quack. If he doesn't get well, then he would look at a doctor, which may be a doctor or a compounder at a PHC. He doesn't go well, if it is not recovering, then he would look at somebody else where he refers. So when he reaches a secondary care or a district hospital, it's already possibly 10 to 14 days. And sometimes damage has been done. I have worked in Kochi because of Amrita Institute at 18 years. The Kerala healthcare indices are so brilliant, only because what you mentioned about health-seeking behavior, because it is directly proportional to literacy. If any doctor writes review after 3 weeks, 6 months, he or she will definitely come after 3 weeks. Now we have shifted and built an institute at Haryana. Nobody comes because they are all again looking for falling sick seriously to come and visit the hospitals. And that is where a phenomenal change in our mindset has to happen. Before this, we were talking about a lot of westernization. So even in medicine practice, we have been unfortunately very US based, and our day-to-day adoption has been Western in nature. Our founder, Mata Amritanandmayi, used to say that unfortunately we have taken all wrong practices and good practices have not been taken. And she gives an example. We have a program called Live-in Labs, where our engineering students, medical students, goes to the village, stays with them, understands their problem, and come back and look for solutions. So our engineering students, medical students, they go, they stay. When they come back, they start crying, and they say, people can live in such modest way, and the needs and the wants have to be really so simple, and all can be done. And they cry for 5 days, understand it for 7 days, and then they join their usual program. Similarly, we have a program, we have a MOU with Bloomsburg University, Harvard Medical School. These people, these students come, they also go stay, they also realize how in modest way things can be easily lived. They don't leave it here. They go back, they write their experience. They would try hard to publish it. Then they would try hard to look at grants and funding and make this program bigger. And that is where our founder, Amma, says that unfortunately all bad practices, KFCs and McDonald's we have adopted, good practices of writing, publishing, collecting data, writing that experience, sharing, making it big, doesn't happen. And that is where I think you and I, all of us, needs to sort of come back and really rejig ourselves to be able to sort of make that kind of a difference. We have seen lots of myths are there that is so fantastically elucidated by Dr. Ripin and Dr. Rakesh, and I also learned quite a bit, and thank you for sharing that. Prevention would be the key. Unfortunately, we have become very curative in our approach. So those BP screening programs, the dietary restrictions, the yoga and meditation, falling very early, and good clinical care with single pill control, which they said would be very, very critical. I just hope that today's deliberations would be very productive. And as Mr. Anil Rajputji said, can we go back and create a ripple effect and impact on 100 more people so that the whole message falls for all the community at large, and India at large would be benefited. Thank you so much for participating.
Thank you very much. With this, we conclude the inaugural session. May I request the dignitaries to please come together for a group photograph. Post this, we'll be presenting a token of appreciation to our dignitaries. To please first come for a group photograph. And may I now request Mr. Anil Rajput to please present a token of appreciation, a token of respect to our dignitaries. Sir, to kindly present it to Mr. Rajesh Bhushan, sir, to please step forward. We now present to Professor Rakesh Yadav. Dr. Ripin Gupta, kindly keep the applause going. Dr. Sanjeev Singh. We once again thank our esteemed dignitaries for joining us for the inaugural session. Can we please give it up once again, ladies and gentlemen, for sparing their valuable time and sharing their expertise with all of us. Thank you once again. And now we'll quickly prepare our stage for our upcoming session, which is a panel discussion on managing hypertension during pregnancy, from risk to safe motherhood. We aim to begin in next 30 seconds. We would request you all to kindly remain seated. Our upcoming important session will focus on early identification of hypertensive disorders during pregnancy, recognition of warning signs, prevention of maternal complications, fetal monitoring, and the importance of long-term cardiovascular follow-up, and a lot more. We once again request you all to please remain seated as our stage is now set. To moderate this very important and insightful session, may I now invite on stage Dr. Renu Rena Sehgal, Chairperson, Department of Obstetrics and Gynecology, Artemis and Daffodils Hospital, Gurugram. Can we give her a more energetic round of applause? And our esteemed panelists may enter from they may use those stairs. A very warm welcome to you, ma'am. Thank you very much. Please be seated. Joining her on the panel are some of the most respected experts in women's healthcare and wellness. Please welcome Dr. Hem Sweta Srivastava, Director Professor, Department of Obstetrics and Gynecology, University College of Medical Sciences and Guru Tegh Bahadur Hospital. Kindly keep the applause going as we welcome our esteemed panelists on stage. Dr. Piki Saxena, Director Professor and in charge of Assisted Reproductive Services, Department of Obstetrics and Gynecology, Lady Hardinge Medical College and SSKH, New Delhi. A very warm welcome to you. Dr. Alka Chaudhary, Senior Consultant, Department of Obstetrics and Gynecology, Madhukar Rainbows Children Hospital, Malviya Nagar, New Delhi. Kindly keep the applause going. Dr. Shikha Sharma, Scientific Mentor, Ranfort Wellness. Can we please extend a very warm and hearty welcome to all our distinguished panelists. Thank you once again, and once again a very hearty welcome to all. With this, I hand over the session to our esteemed moderator, Dr. Renu Rena Sehgal, to lead the discussion forward.
A very good morning to all of you, and I hope to change the mood of the morning to good things, happy endings. That is what we all obstetricians and gynecologists and lifestyle coaches in my panel hope for. As we move towards the goal of safe motherhood and reduce the maternal mortality and morbidity, hypertensive diseases of pregnancy still continue to pose a significant critical challenge to modern maternal medicine. Globally, the new impact is that it has now forms the 5 to 10% of the pregnancies driven mostly by the advanced maternal age and the global pandemic of obesity, which the earlier panel talked about so much. We are witness to about 15% rise in global incidence of hypertensive disorders of pregnancy and a staggering 487% rise in prevalence of hypertensive disorders of pregnancy in the past 3 decades. Today, we will move from what it is to how do we handle it better, and from beyond just managing to mastering the path of safe motherhood. In this panel, we will examine the clinical framework and preventive strategies, not to just secure safety in pregnancy, but also to protect the long-term health of our pregnant women. Joining us to break down these strategies, as we have a powerhouse of esteemed panelists who are experts in their field. I welcome Dr. Piki Saxena, Director Professor of Obstetric Gynae at Lady Hardinge Medical College, Dr. Himsweta Srivastava, who's again a Director Professor, Department of Obs and Gynae at UCMS Medical College and Guru Tegh Bahadur Hospital, Dr. Alka Chaudhary, Senior Consultant, Department of Obstetric Gynae at Madhukar Rainbow Hospital at Malviya Nagar, Delhi, and Dr. Shikha Sharma, medical doctor and a scientific mentor at Ranfort Wellness. I welcome you all, and without wasting much time, let's begin the panel discussion. And the first segment for me would be risks and early warning signs. My first question to Dr. Piki. Dr. Saxena, let's start with what are the primary types of hypertensive disorders in pregnancy?
Okay. So I think we are addressing a very, very important problem because it is not only focusing on the mother, but also the baby. And all the hypertension, diabetes, obesity, these are also going to lead to the intrauterine programming for the baby. So they are going to have long-term implications for the mother and the baby. So let us first understand what are the types of hypertension. The first one is chronic hypertension. Hypertension per se is when the blood pressure of the mother is more than 140/90, which is measured 2 times 4 hours apart. And if the mother is having high BP before she becomes pregnant, or it is discovered before 20 weeks or 5 months of gestation, then we say it is chronic hypertension. That has long-term implications, and even after delivering, the BP will remain high at 6 weeks. The next comes gestational hypertension. When we have the same values of high BP, and they are discovered after 20 weeks of gestation, that is 5 months of amenorrhea, and these are not accompanied by proteinuria or any organ dysfunction or any placental dysfunction. Third category is the most important one, which is preeclampsia. And preeclampsia is the same BP records with either accompanied by either proteinuria or having organ dysfunction or placental dysfunction. And then if this mother, the preeclampsia patient, has fits and gets very high BP, then that is known as eclampsia. So this is the fourth category. And sometimes in chronic hypertension, there is development of superimposed preeclampsia. So these are broadly the 5 ones, and the BP categorization is the same. We need to remember this target BP of 140/90.
Right. Dr. Srivastava, the next question to you. We all know early identification is crucial. What are the women, which type of women, are at the highest risk of developing high blood pressure in pregnancy?
There are some factors when a patient comes to us for her antenatal checkup that we have to rule out to determine in which risk factor she is. The various bodies have given high risk factors, some moderate risk factors. So the highest risk factors for developing preeclampsia are those patients who have some existing disease, like they are having chronic hypertension, as Dr. Picky said, because now they are a very high risk. Then they can be having some diabetes, which can be type 1 or type 2 diabetes along with pregnancy. They are at a very high risk of developing this preeclampsia or high blood pressure. Then having any kind of kidney disease or any kind of autoimmune disease like APLA syndrome or systemic lupus erythematosus. These are the highest risk factors. The other not so high risk factors, but still they are important. They are the moderate risk factors, which belong to like nullipara pregnancy, like first pregnancy, very early age. Then high BMI. A patient, she may be just first pregnancy, but she is very obese, which is a problem now. So weight more than 30 kg, BMI more than 30 or a higher weight. Then having a family history of preeclampsia in her parents or first cousin, like mother, father having chronic hypertension. Then another high risk factor is having a previous pregnancy, she was having preeclampsia. This will be as a high risk factor. Then other not so high risk factors would be past history of, I told you, the family history of hypertension and the other risk
Family
factors
history of stroke, I think, if they have.
IVF pregnancies, yeah. Nowadays, we are seeing quite a lot of IVF pregnancies, and a patient who's having an inter-pregnancy interval of more than 10 years or less than 2 years are also at high risk of developing high blood pressure. Multiple fetal gestations.
Having discussed this, that there are many women who have pre-existing risk factors, it is very important for us to know that many patients, in fact, more than 40% of the patients may develop hypertension in pregnancy without any known risk factors. So a pregnancy is an independent kind of risk factor for developing a hypertension. Dr. Alka, for women with chronic or pre-existing high blood pressure who are planning a pregnancy now, they know they are hypertensive, they are planning a pregnancy, what would be a gold standard workup and what would be your primary suggestion to them?
First of all, if the patient is of chronic hypertension, she must be on some medicines to control her BP initially only. If the BP is more than 140/90, we need to lower it down. It should not be higher than this. First step is measuring the BP, controlling the BP. Second step, we go towards the blood test. Blood test by seeing a CBC count to look for platelets, hematocrits, then looking at the liver function test in which the liver transaminases are very important. If they are more than double, that means the patient is already having liver damage a bit. Then going up to ECG and echo to look for the underlying cardiovascular diseases. Maybe they are already suffering from some structural heart disease, which can be picked up on echo, or ischemic heart disease. These should be ruled out by an echo and ECG. Then looking for kidney functions. Why? Because patient may be having some underlying kidney disease, which is the cause of her chronic hypertension, leading to her essential hypertension basically. So for the kidney functions, we need to look for KFTs, in which serum uric acid, serum electrolytes are important, serum creatinine is important. The baseline serum creatinine should be normal, in the normal range. Then looking if the electrolytes are imbalanced, then we may think of secondary causes like pheocytochroma, Cushing syndrome, aldosteronism. So such diseases which are secondary should be treated by the specialist beforehand reaching to the pregnant stage. Now looking for proteinuria. Second step, as Dr. Picky said, there is a definition known as preeclampsia. Preeclampsia is it is identified as preeclampsia when the BP is high, along with some protein is secreted in the urine. How much? How to measure? It is 24 hours urine protein is to be measured. That is the gold standard, but everyone of us know it is bit cumbersome to record, to collect 24 hours urine and send it to lab. So another test has come into the place which is equally accurate and have better results, that is known as spot protein is to creatinine ratio. If more than 0.3, it signifies that the patient is having preeclampsia. So this needs to be checked up beforehand.
And I think these are the ladies are the ones in which we should have a direct collaboration with the medical team so that we can be on the same page. And yes, also important is that we should be changing their BP medications to such that which are compatible with being safer in pregnancy. Dr. Sharma, looking at from the lifestyle perspective, how can we use patient's constitution or prakriti as you call it and specific food choices before pregnancy to proactively help them to mitigate the risks of hypertension in pregnancy?
I think that's a wonderful question. So like Dr. Rena said that my beginning was as a medical doctor and as an allopath in GV Pant Hospital, and the reason I moved into holistic care was because I realized that most of the lifestyle disorders we are treating in the hospital, the other arm is missing, which is lifestyle correction. So first thing what we have to understand is that in lifestyle correction, we have to understand the personality of the person. We cannot give the same solution to everybody. Pregnancy, according to the Vedic sciences which Honorable PM is now pushing and suggesting that we all adopt and understand, basically says pregnancy is a air and fire change, which means the energies in the body, the fire increases, the air increases. Now let's understand it very specifically. First we have to understand what is the DNA or what we call as a prakriti of the person. The prakriti means your DNA. That means if you already have more air, which means anxiety, if you already have more fire, which means anger issues, which means inflammatory constitution, or do you have more water energy, which is basically pedal edema, weight gain tendency. So now if my patient is coming and if the person already had an air imbalance, I would first fix the sleep and I would tell the patient that please don't have drying foods, popcorn, or too much of tea or coffee, or too much of missing your meals, because it will further push your air, which means hypertension. So the disorder of air is hypertension. The disorder of fire and air together is eclampsia. So that means you have to balance those energies. But it's not only through food. Of course, with air, you will not say that please go on a fat-free diet. You will give little ghee, but organic ghee, not the chemical ghee which is coming out, not the Malaysian trans fat palm oil, which is mixed in refined oil. You will give cold pressed oils. In foods, you will give easy to digest foods. So you will not give something like a pizza, because pizza is very hard to digest. The wheat and the cheese is the hardest to digest for a pregnant woman. Also, if her intestines are not balanced. Also, if she's used to taking too much medicines, which has affected her gut biome. So what I'm saying is, in simple thing, that you look at the patient, you identify what is her basic constitution. Based on that, 3 things will be told: what to eat, when to eat, and because it's a very long discussion, I don't want to be talking only. We forget 2 very important things in pregnant women: the second heart, which is the calf muscle, and breathing. If the breathing is not correct, blood pressure can never be managed properly. So teaching her breathing, a lot of nice places have lamas and a lot of other things where you teach breathing, you teach movement, you teach calf muscle exercises, but all places don't understand. So they think it's fancy. Don't do lamas, do something else. But calf muscle exercise and breathing exercise along with nutrition is really critical.
Thank you so much. Now our patient is pregnant. We move towards an early detection and monitoring. My first question to Dr. Saxena: why is regular antenatal care so critical for managing hypertensive pregnant patients? And how does the clinical management differ between a chronic hypertension and a gestational hypertension?
So I think it's a very important practical question. And first of all, I would like to say that whenever I find that a patient has high BP, it is very, very important that we tell her to buy a BP app and teach her how to measure the blood pressure accurately. Because they are spending so much money on useless things like pizza and all. So they can easily buy, and it is a very, very important thing. Going for a patient to get the BP measured from a GP or a nurse, it is very difficult. Sitting in the privacy of her home and measuring the BP at the same time, how frequently she has to measure, all those things need to be told. And it is very, very important that we monitor her whenever it is a high blood pressure which is encountered in pregnancy. It has to be a consultant-led care, and the patient has to be serially monitored, because during pregnancy, because of the physiological changes, the BP may shoot up any time. And it is not just the mother who is at risk. There are so many complications which can occur to the mother, starting from the CNS. There can be stroke, there can be fits, there can be left ventricular failure, there can be pulmonary edema, there can be epigastric pain which is accompanied by subcapsular hemorrhage, HELP, kidney problem, acute renal failure, and then placental problems which can lead to fetal growth restriction or sudden IUDs. So all those things have to be counseled to the mother and her caregiver. Mother-in-law जो आती हैं, उनको अंदर बुला के उनको समझानी है ये सब चीज़ें.
It's very important in our perspective to talk to the mother-in-law. It's very, very important. Even if you make jokes about it, it is a very, very essential part of the management thing which we have to discuss, because you have to make them understand that there is a potential risk not only to that girl but to the baby as well.
Also to the baby. Yeah. And same time पे दवाई खानी है, रोज दवाई खानी है. How essential it is for treatment adherence, that has to be told. And in case of chronic hypertension, as Dr. Alka said, all those workups have to be done early. And again, gestational hypertension is very important, because any time BP ठीक चल रहा है, but any time it may shoot up and it may become very serious, like all those complications that I said. So it has to be a very close monitoring. It's a high-risk pregnancy and has to be
regular
monitored.
antenatal checkups have to be emphasized.
Absolutely.
We have to tell them that the blood pressure can come without any warning signs. Like they said, it's a silent killer. So you may have a high blood pressure. Before you get symptoms, it may be too late.
और BP नापने से पहले उनको 5 मिनट बिठाना है, and they should be back rested, should be there, no tea, coffee, खाना नहीं खाना है, or it should be at the level of the arm, should be at the level of the heart, and ठीक से blood pressure, BP, कफ किस size का होना चाहिए, Because if she is obese, she will need a bigger, it should cover 80% of the arm circumference. Those are some of the very important practical things. And पहली बार जैसे पिछले speakers ने भी बताया, first BP high आता है तो उसको 10-15 मिनट rest कराएं और दोबारा
And
measure
then
करें.
again take the BP. That has to be a strategy.
Very, and the patient should write down. हम लोग क्या करते हैं एंटीनेटल शीट्स पे टारगेट बीपी लिख के देते हैं, टारगेट ब्लड शुगर लिख के देते हैं, एंड शी हैज टू मॉनिटर एंड ब्रिंग द चार्ट
to us.
और कभी भी हाई बीपी आते हैं तो रेड फ्लैग है, एंड वी राइट डाउन ऑल दीज. हमारी एएनसी कार्ड में we have written all these danger signals.
We will come to that.
So,
we'll come to that.
Yeah, so patient should be counseled about that.
So, Dr. Srivastava, in our plethora of whatever clinical judgment and tests we have, the best screening clinical test available to predict the risk of high BP developing in a pregnant woman at this stage?
Yeah, actually the patient has come, so we have taken the history. So we have already filtered through history the risk factors. So that is one screening modality, through the history. The next screening modality is through the clinical procedure, like when we take her blood pressure, which we take every visit. So a higher mean arterial blood pressure is an indicator that this patient will develop later on in her pregnancy a high blood pressure. So a higher MAP. Then there are some biomarkers also, which are nowadays they have been proven to be very good and accurate, of which it is
The uterine
SFLT1, the uterine artery Dopplers. So we do that, usually we do the ultrasounds in the second trimester when we do a targeted scan. But nowadays the importance of a first trimester scan, that is at 11 to 14 weeks, is very, very important.
Has to be emphasized over and over again.
And to be done. Because there we do the uterine artery Doppler, where we can find the notching or the different changes which can predict the presence of or development of preeclampsia or early onset preeclampsia in those patients. And then we talked about the biomarkers like SFLT1 and PLGFs, which are, if PLGF is low, then it is predictive of developing a high blood pressure later in pregnancy or early onset, or SFLT is high, then also it indicates. So there are cutoff values.
The ultrasound per
ratios
se,
also.
when in Indian
It's
scenario,
very
when we
important.
talk about the cost effectiveness, that one single ultrasound is a big, makes a big difference when we have checked the uterine artery Dopplers. Dr. Alka, we have now high uterine artery Dopplers. What is one preventive medical therapy that effectively has been shown to lower the risk of high BP developing in a pregnant woman?
WHO recommends low-dose aspirin 81 milligram to be started in such patients. We, being at Rainbow Hospital, we are doing this multi-targeted approach where we do the screening between 11 to 13 weeks, as Dr. Shweta said. We check upon the high-risk maternal factors. We take the uterine artery Dopplers along with PAP-A and PLGF, collaborating all of them, putting into a system and taking out the risk. We screen them as high risk if the risk is 1:100, and then we start them on EcoSpray.
A simple small tablet of low dose aspirin can go a long way, cheaper modality, long way to help us prevent the preeclampsia coming at an early stage. They may not come, they may come still, but there will be a considerable delay, and we can prolong the pregnancy and save the baby from
They should be
complications.
ideally started between 12 to 28 weeks as early as possible.
12 to 16
16 is the
weeks
best
the
one.
Ideal,
Yes, ideal one.
Ideal time between 12 to 16 weeks. If we start at 12 to 16 weeks, we give them the best protection.
Because this is the time when the placenta is developing, the spiral arterioles are having that invasion into the the placenta, so that develops hypertension at this stage, basically.
I come from the clinical side and then I go to Dr. Shikha. Dr. Shikha, when a mom is told that she is at risk, the anxiety increases, then there is a vicious cycle. So how do we break that vicious cycle? What is one simple daily routine you will tell to a pregnant lady to lower her stress and to positively affect her BP? Are there any exercises, diet changes, or any other modality? One gold standard you will tell to every patient.
I think the first thing what we tell to every patient is, of course, that the only way to control your mind is through your breath. And teaching every pregnant woman, I would say teaching every human being, but at least since we are discussing about pregnancies, is teaching them how to breathe correctly, and especially because pregnancy, especially for the first time pregnant mother, is a new experience. And there are a lot of doubts and worries in her mind. So breathing is the first thing we tell her. Second thing is we also educate her what's really happening, because uncertainty breeds anxiety. So we explain what's really happening with her body. This is called participative medicine. And like I said, calf exercises, light body massages. Why? Because as you soothe, the healing touch of the hand is very, very important. So as you soothe your body, and of course, we also explain to her the basics, which is hydration. I don't think our women are drinking enough water. Now, if your body is full of cortisol, if you're only eating food which is heavily cooked, you are losing out on enzymes, your gut biome is not healthy. So what we try to tell her is that not eat this to get this, but eat this to heal your body and develop your baby inside in the most holistic way. So like I said, breathing is the gold standard. Light body massages, calf exercises are very important. Having as many greens as possible.
Involve the husbands. Let them do some work. Some massages will help, है ना? कुछ काम तो वो भी करें 9 महीने में.
Yes. And a lot of greens we tell them. See, most of the time people focus on milk products, people focus on heavy food. What we are telling them, that greens and fruits like anar, we suggest to every woman, have one anar, also because of the context that ek anar so bimar, meaning that anar is always very popular all over the world. So we tell them start having anar, and that's the only time, frankly, a woman is pampered. The first time a woman takes care of her health. Otherwise, she thinks I'm a second citizen.
She's treated as one. This is one time when she's pampered, and we go back and tell them, go to the sabzi mandi and see all the colors. Bring all the colors home. I think that should be a takeaway.
Yes, it's rainbow diet. So we tell her to fill the colors on a plate like a rainbow diet, and that's how we work. But I think the core is basically simple rituals where we make her as a participant rather than as a patient. So we involve her in the whole process. So that's how we really work.
Dr. Saxena, I come to the next point that you were discussing. What damage does high blood pressure cause to the placenta and the baby? And under what emergency medical situations do we have to deliver the baby before 34 weeks?
So as we discussed earlier also, the high blood pressure can cause damage starting from the brain. It can cause stroke, it can cause fits, it can cause left ventricular failure, it can cause pulmonary edema. All those things can be there in the placenta because of the decreased blood supply going to the baby. The growth of the baby is restricted, and the amount of liquor which is formed by the passage of urine of the baby is less. So anytime there could be cord accidents, there could be abruptio placentae, and there could be sudden deaths, stillbirths. So all those things are very much happening even when everything is going all right. We are monitoring we are doing the fetal surveillance by different means, which I think will be discussed later.
Yeah.
So all those things we are doing, but sometimes suddenly we get an IUD. So those are the things which can happen. And generally we tend to deliver these women by 37 weeks, but in certain cases when there is a severe hypertensive crisis, that is blood pressure more than 160 by 100, or when the BP is not getting controlled with medications, one step, two medications, or she's developing any of these complications or health, or the fetal well-being is compromised, that is on NST we get fetal decelerations, or there is absent or reversed diastolic flow in all those cases to save the baby and the mother, or pulmonary edema. In all those cases, we need to deliver the woman before 34 weeks.
Dr. Srivastava, we haven't reached a critical stage yet. We have just diagnosed a pregnant woman as 140/90 BP. And how do we tell them to monitor at home? What should be our strategy? Though Dr. Saxena had given us a little bit of idea, I want you to elaborate on that.
So we must impress upon the patient, as Dr. Piki said, that she should have a BP machine at home. Because it's very, very important. Although we call in the initially patient at 1 month or 3 weeks to come for the antenatal checkup, but at home having a BP instrument is very good for her, that she can take her BP records and BP checks daily and at different times of the day. Early in the morning on getting up, maybe in the afternoon when she's more tired, then we can know what's the pattern of the blood pressure or whether, and she has to make a chart.
Yeah.
So the chart can be made by the doctor.
That
chart can be given by the doctor.
Yeah, that chart
she has
helps
to fill
us.
it.
She has to come back to our antenatal visit with that chart.
With her charts. And with her charts, we can know whether this BP, what's the trend of the blood pressure. Whether it is going slowly rising or not, or whether she's keeping it at level, or at what time of the day she's having
more blood pressure.
This blood pressure.
Dr. Chaudhary, what are the clear danger signs or red flags when a pregnant woman has to come to the hospital or emergency?
A patient with chronic hypertension or preeclampsia or gestational hypertension, any of the three categories, if has severe headache, intractable, not treated with NSAIDs, blurring of vision, visual scotomas, flashing of lights, sometimes the patient may see edema on hand, feet, or around the eyes, known as periorbital edema, these three things, or fit, actual fit, either clonic, tonic, focal, or multifocal fit patient is throwing, that is termed as eclampsia. In such situation, the patient should reach hospital. Last one, but not the least one, the epigastric pain, which may be a roundabout right hypochondric pain because of the stretching of Glissen's capsule or parenchymal hemorrhage in the hepatic area.
I think we need to emphasize this more. You know, the epigastric pain is usually trivialized in pregnancy. Gas hoga, acidity hoga, I can take.
That is the reason we said patient with hypertension, severe preeclampsia, or chronic hypertension. In these categories, if we have this pain, then it is considered to be dangerous because we expect this patient is going into HELP syndrome basically. Her liver enzymes are going to be elevated. Her liver is actually involved. There is inflammation, hemorrhage in the liver. The Glissen's capsule is getting swollen up, stretched up, and because of which the pain is there. And these patients require a multidisciplinary approach, cannot be treated at the primary healthcare center, so should reach a center with an ICU, hepatologist, anesthetist, ICU, all the things available at the same place.
Dr. Srivastava, like she said, a multidisciplinary approach. What is the critical situation where we have to know that now we need a multidisciplinary team? We can't manage it alone. This patient has to go to a tertiary care center.
Because when these patients we are monitoring, as with the blood pressure, we have also to monitor her hematological and biochemical parameters. So if we are doing a hematological count and platelet count is falling, going below 1 lakh, her liver enzymes are rising, they have doubled, AST, ALT have doubled, the serum creatinine levels are more than 1.1, or she is having these blurring of vision and maybe epigastric pain, then we have to involve a multidisciplinary approach in the sense that for if she's having this stretching of the Glissen's capsules and all, we have to consult a hepatologist. She may be developing a hematoma, we might require a surgeon, or in cases of low platelet counts, we have to consult a hematologist, that we have to bring her platelets up, and probably this is the time to deliver or terminate the pregnancy. Then what will be the implications when she will bleed? So do we need some transfusions? We have to bring her up or not? Then we have to have an ICU team ready For that, we have a patient in
To
labor
receive
room.
such patient.
Yeah,
This
to
is
receive
very
such a
important.
patient, because she will require anesthesia or intensivist support. And the anesthetist has also to be informed and well informed that such a patient might deliver. We need analgesia or anesthesia for her cesarean delivery. We might require a faster or a quicker termination of pregnancy.
Dr.
So
Saxena,
these are all.
next question to you is, does the diagnosis of hypertensive disorders of pregnancy automatically mean that a patient needs a cesarean section? That is a myth that we all carry around. And how do we keep the blood pressure stable during active labor?
Just one point I wanted to add. If the patient is anytime breathless,
Yeah.
or she gets a fit, or she becomes unconscious, those are the other three conditions where we need to involve the medicine people,
team.
the other team persons very quickly. So, of course, if the patient has got a high BP, it is never that she cannot deliver vaginally. All should go for vaginal delivery unless they have these complications and we need to terminate. If she's having pulmonary edema and she goes into labor, she'll not be able to bear the stress. So in those cases, we need to go for cesarean. Otherwise, only for obstetric conditions, we need to go for cesarean section, and we should check the Bishop score. That is how easily the woman is going to deliver if she's a multi, and all those things need to be checked, and she can be taken in for a normal vaginal delivery. BP has to be measured very frequently. She has to be given labor analgesia, epidural if possible, and her BP, urine albumin needs to be maintained, and the doses of hypertension need to be titrated as per the requirement. If she is having pulmonary edema, then we may prefer NTG. Or if she has any signs and symptoms which we have been discussing since the beginning, then we can start her on Maxer. So all those things need to be
The
taken
role of
care
Maxelf, of course, we all have to know, is the magnesium sulfate has
Prevention
been
of,
since it has come, it has
fits.
been our savior and preventing so many eclampsias from happening.
Eclampsia, it is the treatment for eclampsia, it is prevention of
Prevention of-
eclampsia, and in preterm babies, it helps in neuroprotection and also causes sometime prevention of uterine contractions.
Contractions,
So it's a uterine relaxant also. So many uses.
Dr. Shikha, how do we ensure that the hypertensive patient remains calm in labor? And what role do husbands have to play as birthing partners?
Very tough question. So I think what we call is the biofeedback, that when you are stressed and anxious, if you can at that point of time give them biofeedback in terms of relaxation, in terms of measuring their BP and counting. So what happens is that the person's mind, which is going into a loop, gets focused on something else, and that is very important, that you have to change
Shift
the
the
focus.
focus.
You have to shift the focus. Now, in a country like ours, a lot of mothers have mantras, which is basically they chant during that time. A lot of people pray during that time. A lot of people, count their rosary during that time. I think it's fantastic because what happens is it gives you a focus with faith. So faith and focus together is the fantastic relaxer
Combination,
of the...
fantastic combination, I agree.
Yes. And I think as far as the husbands are concerned, the only thing I would tell them would be that to understand the woman, understand she's going through a situation where it might be the first time for her, where she's going through it alone, literally alone, the pain and everything. A little understanding and him being calm helps. So if the husband also goes into anxiety, it doesn't help at all. So it's very important to get the family...
It's very important to get the family involved, and it's very important that the husbands serve as communicators between the doctor and the patient, and they try and boost the morale. I think we need morale boosting at that time the most. I think it is very important.
I think the government of India, Laksh Initiative, they have introduced this concept that husband or any other
Other birthing
companion, a
partner.
married woman who has herself delivered earlier or who is in close sync
Mother,
with the
sister,
woman.
anybody,
Sister,
you need to have a
sister-in-law.
birthing partner.
And they are also doing some types of massages, the
Massages.
back massages, the calf massages, which calms the patient. And there are different birthing positions also now, and there's a big role of the nursing staff which is coming up, who are very trained nursing partners who are helping in giving birth to the woman. So, because this is the worst type of pain, and labor analgesia, breathing exercises, companion, either it is husband, as Dr. Shikha said, that husbands are sometimes very worried. So even holding hand of the husband in our government hospitals, husbands are not allowed, but we are allowing one married woman who is experienced, who can help her and calm her to be in. That plays a major role.
Dr. Srivastava, most patients believe that the risk of the mother ends with the delivery. Whereas data shows that first 2 weeks postpartum have the highest risk period for eclampsia. Why does this happen and how can we prevent this?
Yeah. This entity is called postpartum eclampsia. Many times it has been seen that the antenatal period has gone uneventful, the delivery has gone uneventful, but the patients develop postpartum eclampsia, and that is a very that leads to a worst outcome for the maternal deaths even in postpartum eclampsia. And that is why a vigilant eye and the red flag told to the patient comes a long way in preventing a major complication after delivery. And this happens, it happens in the 6 weeks period, but most important periods are the 2 weeks, the first 14 days. And this happens because whatever damage was there due to this, we had this high blood pressure, the endothelial dysfunction or malfunction, that continues till, it does not just go away soon after delivery. It heals, the endothelium heals, it takes time. So the damage is still there, the pathophysiological process is still going on, and plus combined to that, then the anti-angiogenesis factor which were in play, they have also not disappeared suddenly after delivery. They are still there. So for first 14 days are very, very important. Plus the anxiety in the patient that she is not able to sleep. Suddenly a lot of halla hulla is there. And
Too
her
many
sympathetic
people
overdrive
giving too much
is
of
there.
advice in our Indian scenarios.
Don't
there
eat
are
this.
birthing, there are
Don't
feeding
eat this.
difficulties,
Yeah.
there is stitches, be it
Pain is
episiotomy or
there.
cesarean, the pain is there.
Sleep cycle is disturbed with the baby now. So all these things adds to the stress of the patient, and then she can develop this complication which is postpartum eclampsia. So
We have to emphasize a follow-up visit. We have to emphasize on a 5th day and 2-week follow-up visit of these patients particularly.
Usually in government setup we are calling at the end of the puparium, but in high risk preeclampsia patients, we are keeping them for more than the 2 days. We are keeping them for a week, monitoring their BP, whether it's gone, and emphasizing that she has to take her medicines, and the red flags are told to her. Having severe headache or blurring of vision or some kind of pain, then she has to immediately report. She has not to miss her drugs, and the family is also involved in this so that they take care of the baby while the patient gets rest. That is very, very important to emphasize, because otherwise
Dr.
she'll come
Shikha,
back running.
a few lines on postpartum kitchen pharmacy to heal the endothelial damage.
See, the first thing I would say is immediately postpartum in Ayurveda, it's called a Vata situation, because Vata means that the baby has been born. So there is a gap, there is a space which is getting filled very rapidly with energies. During this time, it's very important not to go and start having your favorite ice creams and your favorite foods, because the body is healing. And when the body is healing, basically food is becoming your body. The repair material is food. So warming spices are given. Warming spices, like you have a little bit of ajwain water, you have ginger water, you have fenugreek, methi water. Why? Because the body to heal needs that kind of energy. Second, in fact, in Ayurveda, there is a complete chapter written on the entire 9 months of pregnancy and what should be done, what should not be done. Second thing, it is very important not to have salads during that time. Of course, from a hygiene point of view, it's different. But why? Because salads are very vata in nature, very drying in nature. So it's very important to have sauteed vegetables. You can have lightly sauteed, it need not be completely fried and all, but lightly sauteed vegetables. According to the Prakriti, if the woman had high fire, then cooling things like, but not cooling in temperature, but cooling in tasir, or the post-digestive impact of the food. Those things have to be taken. Like for example, especially in summer time, little bit of coconut water can be given for hydration. Hydration has to be looked after, no refrigerator water. It is also important that when you're having seeds, so you have to roast the seeds a little bit, because they're rich sources of calcium. That has to be given. One thing which I forgot to mention is, and which I would say every family which can afford, please only choose organic, because the high levels of pesticides in the food can really cause intergenerational damage to the DNA. So make sure that during the entire pregnancy period, organic food, especially organic milk, organic dairy, everything is organic, because otherwise the oxytocin from the milk which is being taken can affect the mother also. Liver has to be looked after. That means a lot of fruits have to be given, because liver is the site where what we are seeing is a lot of women are coming with fatty liver, and a lot of women are coming with liver disorders pre and post pregnancy. So the liver has to be detoxed, and only fruits can detox the liver. And of course, I would say the traditional khichdi is great, but keep having different kinds of khichdi. It need not be only rice khichdi, it can be different barley khichdi or other kinds of. So which means a slightly different diet needs to be prescribed during pregnancy and after pregnancy, so that at least the mother gets her nourishment for repair and healing.
I think it is very important for us allopathic clinicians to acknowledge that there are certain dadima ke nuske which have originated from the Ayurveda, like fenugreek water, like ajwain water, like having lots of fruit. They do help our pregnant women. We have seen that they help in producing better milk, they help in calming effect, they help in digestion, and they also help in them to take care of themselves. Thank you very much. And my last question to Dr. Chaudhary, finish this thought for us. Hypertensive pregnant women, pregnancy, this can be a window to the future of the lady. So future health related, what are the long-term chronic health risks in later life, and what screening protocol should be suggested to lower these risks for these women?
See, where we started was when we are diagnosing this hypertension. If the patient has come to us only after 20 weeks of pregnancy, now we have a patient whom we have seen after 20 weeks of pregnancy with hypertension. We don't know it was a chronic hypertension or it was a gestational hypertension. There are certainly still patients who come so late as well. So now we need to follow up these patients post 6 weeks of delivery, which way they are going to go. If they were gestational hypertension only, their BP will settle down, so there is no risk of chronic hypertension in these patients at present. But few patients who were chronic hypertensive, who have landed to us at this point of time, will continue with their BP later in life, so will require treatment for their hypertension as a general patient.
Even some pre-eclampsia
may
patients
change,
will have
yes.
remnant high blood
They
pressure.
will, some will have, not all of them, but they are at higher risk of having hypertension after age of 40 years. So they should be screened at least 6 monthly to yearly for their blood pressures and other factors like what we started with initially, the ECG, echo, lipid profile, the CBC counts, liver enzyme counts, the kidney function test, so as to know are they having any prolonged effect of this hypertension on the organ failure or organ damage to these patients. So they require follow-up for the same.
I think we had a very fruitful discussion. To wrap up, let's look at our 6 most important takeaways. One is to plan ahead, optimize weight and BP meds before conceiving, quit smoking. That is what I like to tell everybody. Know your risks, identify the factors and start low dose aspirin. That is one thing that will help you. Monitor closely. Be vigilant and track BP at home. No excuse of saying, "Main kaise BP dekhungi?" Everybody can track BP at home. Watch for red flags. Never ignore headaches, visual disturbances, and upper right quadrant abdominal pain. Deliver safely. Choose a tertiary care hospital with specialized OBGYN services and advanced NICU and ICU facilities. Ensure postpartum surveillance and follow-up. Please follow these ladies till they are way beyond postpartum. They are the ones who are the half of the society, and they are the ones who are at risk. Hypertension in pregnancy does not always mean a bad outcome. With early screening, multidisciplinary care, and mindful daily habits, safe motherhood is an achievable reality. I have a huge thank you for all our panelists, Dr. Piki, Dr. Srivastava, Dr. Alka, and Dr. Shikha. And I'd like to know if anybody has any questions. And before that, on a lighter note, like the esteemed panelists earlier said that, the doctor prescribed that, the wife should not bother the husband and the BP will come down. We actually try, there are all jokes about it. Even a joke with my colleague, yesterday when they came to know that I am moderating a panel on hypertension, one of my very dear colleagues came and said, Madam, आपके घर में पूछे क्या blood pressure तो नहीं देते हो? So, this kind of situation, we all know that men are more prone to hypertension before women are. We are protected by our good hormones, estrogens. And, but we do need to emphasize special care for pregnant ladies who are going to deliver our future society. We need to give special attention to mothers who are beyond their menopause, and because once they hit the menopause, this silent killer hits them very badly. These are the ones who should have regular health checks and regular monitoring. Thank you very much. Any questions, anybody? To the panelists, most welcome. Yes, please. Yeah, please.
Thank you, ma'am. Ma'am, I just wanted to know, ma'am, whether it is possible, because what I have seen that some medicines and some methods are very much useful in Ayurveda, some are very much useful in homeopathy, and some are in allopathy. So instead of focusing only on one pathy, is it possible to have a combined treatment to the patient? Because what I feel that the pathies are not important, patients are important. So patients should get the right treatment at the right time with no complication. So is it possible?
इसमें मैं कहूँगी कि हमारा जो पुराना वैदिक टाइम से चला रहा है गर्भ संस्कार में मेंटल, फिजिकल, इमोशनल और सारी चीज़ें मिला के जो हम ट्रीटमेंट देते हैं, दैट इज़ द बेस्ट. What Dr. Shikha told us really integrates very well with our allopathic system. और अब गवर्नमेंट इंस्टीट्यूट्स में सब जगह आयुष डिपार्टमेंट है, तो हम लोग अपने पेशेंट्स को जिनको डायबिटीज़ है, हाइपरटेंशन है, उनको भेजते हैं इसमें, जिसमें ब्रीदिंग एक्सरसाइजेस और ये आयुर्वेदिक वाली चीज़ें होती हैं. Although it is not very integrated system, but if we adopt the good things from our earlier Vedic and ये गर्भ संस्कार वाली चीज़ें, हम बार बार मंत्र बोलें, अच्छा म्यूज़िक सुनाएं, और जो हमारी अच्छी थॉट्स हैं, पेशेंट काम रहे, स्ट्रेसफुल नहीं रहे, तो उसकी आधी चीज़ें स्ट्रेस की वजह से जो कॉर्टिसोल बढ़ता है, जिससे ग्लूकोज भी बढ़ता है, बीपी भी बढ़ता है, सब चीज़ें ठीक होंगी. तो आपकी ये थॉट बिल्कुल ठीक है. वी शुड ट्राई टू इंटीग्रेट, बट जहाँ अवेलेबिलिटी है वहीं ये हो सकता है. एंड आपके थ्रू और सभी ऑडियंस के थ्रू आई थिंक ये वाला जो प्रोग्राम है, इसमें हम सब ये चीज़ें आगे ले जाके बताएं, और availability of all these modalities, if they can be combined, it will bring a very good pregnancy outcome.
Okay. Ma'am, you know what, actually what I have seen, because I am a senior sports physiotherapist and I did my training from Japan, Tsukuba University. So वहाँ पर मैम बेसिकली पेशेंट सेंटर में होता है और उसके सर्कल में सारे स्पेशलाइजिस्ट होते हैं. और हमारे यहाँ पर इंडियन में आपका जो पेशेंट है वो स्टेप बाय स्टेप लेटर वाइज लेटर ऊपर बढ़ता है, तो कहीं ना कहीं वो
Actually, that is the challenge in India, but of course, India is developing country and it's doing very well among our treatment process.
We are
हाँ.
developing,
We
our
are trying,
government is also
yes.
helping us develop these strategies. We have to know that our doctor-patient ratio is minuscule, 0.7 some for 1,000. So we are all trying to integrate, we are all trying to come up, and I think we have to let go of our biases that our specialty is superior or anything. We have to take a holistic view, and I think West is also coming back to us and following our age-old traditions, and we are more open and we are integrating. Thank you for your thoughts. I think that we are running late of time, and we will be ending this panel.
Thank you very much, ma'am. May I request Mr. Anil Rajput to please join us on stage. If you have more questions, then you can connect with our eminent speakers during lunch. Can we all please give it up for our esteemed panel for an enlightening session? We'll now present a token of appreciation. We'll begin with session moderator, Dr. Renu Rena Sehgal, ma'am, to please step forward. We'll present a token of appreciation. Kindly keep the applause going as we now present mementos to our esteemed speakers. We present it to session moderator, Dr. Renu Rena Sehgal. Dr. Him Sweta Srivastav, to please ma'am to step forward. Kindly keep the applause going. Dr. Piki Saxena. Please give it up for Dr. Piki Saxena. Dr. Alka Chaudhary. Dr. Shikha Sharma. We now request all our esteemed panelists to please come together for a group photograph with Mr. Anil Rajput. So please come together for a group photograph with Mr. Anil Rajput. Ma'am, to please join them for a group photograph. We once again thank all our esteemed panelists for an enriching and meaningful discussion we just witnessed. Thank you once again. And now, ladies and gentlemen, we will begin the final session for the day on impact of hypertension on heart, brain, and kidney from damage to prevention. We once again request you all to kindly remain seated as we aim to begin in next 30 seconds. Post this session, we'll conclude the conference with lunch. So kindly be with us and kindly remain seated. Our upcoming session will focus on the importance of early detection of target organ damage, routine screening and risk assessment, lifestyle intervention, cognitive health awareness, and most importantly, the evolving shift from disease management towards an organ protection and holistic wellness, starting very shortly. And now, ladies and gentlemen, our stage is all set. To moderate this highly insightful discussion, may I invite on stage Dr. Nitin Kumar Sethi, Chairman, Institute of Neurosciences, Pushpavati Singhania Research. So you can, all our esteemed panelists can also enter from my left through those stairs. Can we please welcome our session moderator, Dr. Nitin Kumar Sethi, on stage. A very warm welcome to you, sir. Joining him on the panel are distinguished experts from across multiple medical specialties. We have with us Dr. Dipankar Bhaumik, Professor and Head Department of Nephrology, All India Institute of Medical Sciences, New Delhi. Dr. Udgeet Dheer, kindly keep the applause going, Principal Director, Cardiothoracic Vascular Surgery, Fortis Gurgaon. Dr. Anurag Gupta, Director, Dialysis Unit, Department of Nephrology, Sir Ganga Ram Hospital. Are we all welcoming our esteemed panelists on stage? Dr. Partha Bose, Senior Consultant Pulmonologist and Medical Director, SSB Hospital. Dr. Avinash Goswami, Consultant Neurologist, Apollo Hospitals, Noida and Delhi. Dr. P. Venkatakrishnan, Director and Senior Consultant, Department of Internal Medicine, Narayan Hospital, Gurugram. Once again, a very warm and hearty welcome to all our distinguished panelists who've joined us. And may I once again request Mr. Anil Rajput, sir, to please join us on stage and present a token of appreciation, post which we'll begin the session. Would request sir to please join us on stage and perform the memento presentation. Ceremony will begin with the session moderator, Dr. Nitin Kumar Sethi, sir, to please step forward for the memento. Dr. Dipankar Bhaumik, Dr. Udgeet Dheer, Dr. Anurag Gupta, Dr. Partha Bose, Dr. Avinash Goswami, Dr. P. Venkatakrishnan, thank you very much, Mr. Rajput, for doing the honors. And with this, ladies and gentlemen, I hand over the session to our esteemed moderator, Dr. Nitin Kumar Sethi, for further proceedings.
Thank you. Good afternoon. I want to thank Mr. Anil Rajput for inviting me, the organizers of the Illness and Wellness Foundation. So the topic which has been given to me, and I like to keep it very simple, very interactive. We have some leading experts from neurology, nephrology, cardiology here. And I would like to pick their minds, and I'd like to keep it in simple language because a lot of the audience here is, in fact, probably all the audience here is non-medical. So starting with a little bit about hypertension, just setting the stage for this session. I still remember when we were as a neurology resident in New York, you read about stroke, and the first thing they say, what are the modifiable risk factors for stroke and what are the non-modifiable risk factors? So, we all have some diseases which there are factors which you cannot modify. So you cannot modify your age. You're going to age. Everybody ages. So stroke, hypertension becomes more common as you get older. You cannot modify your sex. In the last session, we heard about the fact that women, especially when they are before menopause, because of their sex hormones, estrogens, they are protected from heart diseases. They are protected from stroke. But once they reach menopause, their risk for heart disease, for stroke, for high blood pressure, everything increases. Again, you cannot modify your sex. And there are modifiable risk factors. Or you cannot modify your genes. Your father has a history of hypertension. Your mother has a history of high blood pressure. Aapko bhi high blood pressure hoga. It's different. It'll start off in the late 40s, early 50s. But far more important are modifiable risk factors. And I always like this conference because it says illness to wellness. I'm very passionate about the brain. I like to talk about the brain when the brain is ill. But I think we should be more passionate about how to keep our organs healthy. Wellness is more important. So talking in that wellness theme, the number one risk factor for heart disease, for stroke, for chronic kidney disease is hypertension. It's modifiable. We can change it. And you can change it and you can be free of heart attack, stroke, chronic kidney disease. I never used to see so much of chronic kidney disease in Cornell, but now my OPD in PSRI is right across Dr. Sanjeev Saxena. He has a big nephrology practice, and I see these patients on dialysis, and I say this is the worst disease. They come for every three times a week, they come for hemodialysis. They are just sick, the family is suffering, the patient is suffering. So today, what we are going to do is we are going to pick these experts' minds on hypertension. How do we identify hypertension? Remember, hypertension is a silent disease. Many of us in this room have high blood pressure. You'll never know you have high blood pressure till sometime, one day you just check your blood pressure. I'll share something personal. I'm 52. I was in my hospital in New York, and one day my nurse, Helene, I told Helene, I don't feel well, I have a headache. She said, Dr. Sethi, let me check your blood pressure. And she found my blood pressure slightly high. That's the first time I thought, you know what, my father, my mother have hypertension. I'm probably going to develop hypertension when I'm 48, 49. So see, it happened so in a strange way. I was in the hospital rounding, and my nurse asked me, and I checked my blood pressure. So starting with that theme, the first topic we are going to cover is how high blood pressure affects these vital organs: the brain, the heart, and the kidneys. So, I'll start with Professor Bhomik. Obviously, he's the director of, a professor and head of Department of Nephrology. Like I said, I have a very healthy respect now for chronic kidney disease. So, Dr. Bhomik, I see a lot of patients now, chronic kidney disease, coming in with multiple comorbidities. When it comes to target organ damage, the initial signs of hypertension is affecting your kidneys. What are these signs? And in a simple way, a layman, when he or she should be worried that maybe high blood pressure मेरी kidneys तो damage कर रहा है.
Okay, thank you. I'll just give a little background to this, that when we talk of hypertension, hypertension is basically of two types. One is what everybody calls as essential hypertension, and the prevalence increases with age, and many people get it. The term is incorrect. There's nothing like essential hypertension, because hypertension is never essential. That was a wrong terminology. The terminology is primary, means there's no other cause for the hypertension, and hypertension occurs, whatever, there are some factors for it. The other is what is the secondary hypertension, and that is because there is some other reason for the hypertension to occur. So that could be because of primary kidney disease, it could be some endocrine disease, or it could be some neurological condition. So first thing that we have to dissect out, that what is the cause of the hypertension. Now, what happens is that as far as the kidney is concerned, the kidney plays a very vital role in blood pressure control. Let me make it very clear. The kidney controls BP by two mechanisms. One is the volume. It basically controls how much fluid it is able to excrete, how much salt it excretes. And if that doesn't happen, there is fluid accumulation, salt accumulation, there is hypertension. And second is kidney is a very important endocrine organ as well. And there's something called renin, you don't remember the name, but it's a hormone which causes hypertension and regulates BP in fact. So that is one. So kidney controls BP and can cause hypertension. Kidney, unfortunately, is also a victim of hypertension, which he is mentioning. And if BP occurs for a long time, then the problems occur because the filters, the glomeruli get affected. And what happens is then the protein starts leaking. And one of the earliest things which come up is leakage of protein in the urine. So one has to be very careful always to monitor, I'll say, check the BP and check your urine for any albumin or protein in the urine. So if you have these concepts clear, then we can move on from there. And when hypertension occurs for a long time, in the US it has been seen that almost 25% or 30% of all patients who are on dialysis, you mentioned dialysis, actually have primary hypertension, which has gone on for a long time and led to chronic kidney disease or dialysis. So it's very important to control hypertension as soon as possible in a very effective manner. The other thing which happens is if this malignant hypertension, when BP is very high, it shoots up. It can cause stroke. It can cause acute kidney disease as well, kidney failure. So kidney actually is involved at multiple layers in hypertension. I hope that answers the question.
So just emphasizing that again, if you heard what Professor Bhomik said, that the initial signs are again very subtle. I mean, proteinuria, unless aap apna urine dete hain, you'll never come to know you are leaking urine in your protein. So that's one of the very important things you have to remember, that hypertension remains silent. You really actually come to know when you're hypertensive when you actually already suffer something like a heart attack or stroke. Many people come to know like that. Moving on, I'll move to Dr. My colleague, Dr. Goswami. Dr. Goswami, again, same thing. Any early signs the hypertension is affecting the brain, which triggers the patient to say, maybe I should go and check myself out for hypertension. Maybe this is all hypertension, something which is happening in my brain. Any cognitive signs, anything which you think might be early signs that brain is getting affected because of hypertension, apart from like a stroke per se.
As you rightly said, sir, there are certain modifiable risk factor and certain modifiable, non-modifiable and modifiable risk factor for the brain conditions. There are multiple diseases which are affected, which affect brain, and hypertension is one of the most common. When we talk about stroke, hypertension is the most common modifiable risk factor for brain stroke. So if the patient is having intermittent giddiness, so ask patient not to ignore it. So if the patient is having intermittent giddiness, if the patient feels transient weakness of any limbs, it is an important signs of minor stroke. So ask patient not to ignore these things. If the any person is suffering from these problems, intermittent giddiness, intermittent weakness or tingling sensation, particularly on one side of body, any transient visual obscuration, any transient vision loss, the person should immediately contact his doctor and get his blood pressure checked. So if these are the symptoms anybody is perceiving, he must go to the doctor and get his blood pressure checked.
Thank you. Dr. Dheer, you're here from cardiology perspective. So obviously, we all worry about the heart. We all worry the heart is going to stop, we're going to have a heart attack, we're going to die. And as you probably know, there's an epidemic of heart disease in India. So again, same question. Early signs, hypertension is causing some cardiac problem, or at least some cardiac problem which you say, if you're having or experiencing some cardiac symptoms, you should probably go to your internist and tell them, "Bhai, mujhe check out karo." And maybe they find out they have hypertension.
Thank you. First of all, I would thank everyone for inviting me here and putting my thoughts aloud. See, there are certain silent killers. I would say right now there are 3 silent killers which is damaging more rather than anyone. One is hypertension, another is diabetes. And third thing is all leading to tension. So that's why the word hypertension, and aptly said that essential. Essential is not. See, essential, we are getting it as a ethos from the society, from our lifestyle. So I would say there are, the Mother Nature has made our body just like anything which can read. It is the best computer which anyone can make, and it raises the red flags. Whether it is neurological symptoms, whether it is cardiac symptoms, or whether it is urinary symptoms. So my nephrology colleague, they were pointed out that get a urine protein. So I've heard that say that if you have extra froth in your urine, that could be the early sign. Similarly, what about? So heart, how will it speak? Everyone will speak its own language. He talks in Punjabi, he talks in Malayalam, I talk in Hindi and English. The heart will speak in its own language. So what heart language is? It will increase the heart rate. Either it will increase the blood pressure or lower the blood pressure. Point is, we have to monitor. Third thing, it will feel that we have some uneasiness. And point is, as a human nature, we try to find an alibi. The most common alibi is, I had a fight with my wife. That's why I'm not feeling all right. I had 3 cups of coffee. Today my boss did not talk to me properly, or my servant or my driver just calling at the right moment where I'm going for the meeting, because that has caused me anxiety. That's why I'm not feeling. So please don't negate those red flags. Your body is giving a signal. Your body is giving a signal in terms of uneasiness. It could be anything. It could be, first sign could be lack of proper sleep. You are excessively snoring. That could be the first sign that your cardiac and respiratory health is not appropriate. These are small telltale signs. Most important thing, I was just listening to the previous thing and they were talking about, yes, previously हम कहते थे कि एक वैद्य है वो नब्ज पकड़ के सारा मर्ज पकड़ लेता था. Pulse is one such thing which can give so much information, whether it's a neurologist, whether it's a nephrologist, whether it's a pulmonologist, or whether it's a cardiologist, whether it's a gynecologist. The pulse is the most important thing, and we neglect it the most. And COVID has taught us that at least we have those meters where we can check our SpO2 and pulse, so that we can ensure. And for hypertension, the seeds are shown once we are in our teenage. We may be having familial history and all that. I think we should tell from our school days also that you should monitor your blood pressure. There is an exam tension. I'm seeing right now patients, those who are appearing for these NEETs and IITs and all, they come with a panic attack and their blood pressure no one has monitored. Their blood pressure was touching 180. See, point is, if we have to take care of our future, we have to take care of our kids, for the country, for everyone. So these signs, I should say, we should make a curriculum. There is always a medical school in our schools. But point is, no one monitors their blood pressure. I would say, if we have to prevent complications of hypertension, we have to start from the school. We can prevent cardiac deaths. We can prevent strokes. We can prevent multiple patients from going on dialysis and chronic kidney disease. We can prevent people losing eyesight because of hypertension. These are all things. See, I am a heart surgeon and I do a lot of mitral valve repairs. So when I repair and when we check it, so we say that there should be a big smile. Even the heart wants smile in its structure. Why can't we bring smile on other faces? That should be the motto, that we should smile, regularly check up, don't ignore the red flags. That is the most important thing.
Excellent point. I completely agree. And kind of going forward, the point this first thing was trying to make is, when we talk about the three organs we are discussing, kidneys, the brain, and the heart, as the panelists mentioned, the initial signs of hypertension will be very, very subtle. आपको पता नहीं चलेगा कि it's hypertension which is actually causing you these symptoms, whether it's a neurological symptom, whether it's a kidney symptom, whether it's a system affecting a symptom of the heart. And by the time you come to know you have hypertension, the target organ is already damaged. That's the point which we're going to go next, is that the damage has already occurred to the heart. Like our cardiologist was telling us, the arteries are getting damaged at a young age. If your hypertension started when you were 30s, by the time you come to know you're hypertensive, you're 50, 20 years have gone by and your arteries are all damaged. So I'll move to Dr. Venkata Krishnan. He's obviously an internist. You know, many people, the first doctor they go to is, you'll go to your primary care physician, you call him GP, primary care physician, medical internist. So what do you think? What is he mentioned a very good point. Start BP monitoring maybe from school itself. I don't remember, I'm from Delhi Public School right through. I don't remember ever in DPS, at least in my time, my blood pressure was ever checked. Actually, the first time my blood pressure was checked was when I was rounding in Cornell, and that was high. That was when I was long time back. So what do you think is the ideal age where blood pressure screening should become?
Dr. Dheer said about schools. I'm sorry to say, if you come to the hospital also, I see from 15 years onwards the patients in my OPD. 15 to 18 bracket, even the nurses don't check their blood pressure before sending them to my room. So I think that age group, 15 plus, is the place where we start for monitoring of blood pressure, because we are seeing early onset hypertension from 15-year onwards itself, either because of the obesity, many children are obese, and also because the stress level starts rising from the age of 14, 15, their adolescent stress and mental stress, education stress, so many stresses. So I usually feel that it is the 15 or 14 which should be the cutoff, where at least once a year or twice a year BP monitoring of the person should start. And then if it is high, then it should be monitored and referred to a specialist for further management. So that's the point where we should start looking for early hypertension. Then the second stage comes when they enter college around the age of 18, 19. There, the incidence starts rising, and by the age of 21, we are seeing around 20-25% of our patients at that age group of 21 when they join office. The stresses actually starts to come, night shifts, night work, everything. So 15, then probably 18, then probably 21. These are the ages where we should focus, and any patient walking into our chamber or in our neighborhood, any person, we should get a BP check at least once a year or twice a year. This is what I feel, because that is the time when hypertension strikes early before anything, and it's a silent thing at that time. You may not even pick it up, symptoms may not be there. There's nothing, only a little anxiety which we pass off as normal for the child.
Thank you. Dr. Gupta, Dr. Bohomik mentioned obviously the kidneys play such an important role in actually regulating our blood pressure. So it's kind of the same question. Patient comes to you, nurse ne blood pressure check here. At the initial stage, do you feel with respect to the kidneys, any special test should be done at that time to see whether how healthy the kidneys are right at the onset of that disease process?
Yeah, good question, sir. The first thing, till we are talking about the primary prevention, right? I want a little bit, before giving answer to your question, highlight the problem in India. 30% people are receiving the treatment only 30. Out of all the hypertensive, every third patient in urban area is hypertensive, and every fifth patient in rural area is hypertensive. And out of this, the controlled is just 15%. So first is primary and then is secondary prevention. Emphasis on the treatment also. Now, the mostly patients which come to us already has problem. And they have a two common question. डॉक्टर साहब, ब्लड प्रेशर से किडनी खराब हुई है या किडनी की वजह से ब्लड प्रेशर हुआ है? तो दोनों चीज़ों की वजह से हो सकता है. अगर आपको ब्लड प्रेशर लंबे समय से है, ब्लड प्रेशर की वजह से किडनी खराब होने के लिए मिनिमम 10 इयर्स चाहिए. लेकिन अगर आपकी किडनी खराब है तो ब्लड प्रेशर आपको 1 साल या 2 साल से भी हो सकता है. दिस इज एन इम्पॉर्टेंट पॉइंट. तो द सिंपल टेस्ट इज serum creatinine, which may cost around 100 rupees, and urine from microalbumin, which cost around 200 to 300 rupees. And this you can check, and you can check your kidneys. Every person who is above 40 should get done this test, simple serum creatinine and urine from microalbumin, because the prevalence of chronic kidney disease in India is more higher than overall worldwide. If it is 10% worldwide, over India it is 11%. So these are the simple tests which we can determine the involvement of the kidney.
Thank you. Dr. Bose, as people may or may not know, hypertension usually does not occur in isolation. Vascular risk factors go hand in hand. Diabetes was mentioned. So same thing. So the first initial visit, obviously as a pulmonologist, you have also internist. Apart from like urine, routine microscopy, albumin, blood pressure check-in, serum creatinine, what other tests you'll kind of add in that panel? I got my test done from, it was one of those HOD, unka wo comprehensive panel, 1,999. It's kind of very, we'll check you for 250 things. So in those 250 things, for under 2,000, what's useful, what's not?
That's a great question. At the outset, let me thank Illness to Wellness, Mr. Rajput, for giving an opportunity to interact with this August gathering. It's very heartening to see as a multidisciplinary interaction on hypertension, because hypertension is a systemic vascular syndrome. It's not a one-organ disease. And let me tell you, before answering your questions, I feel that this is the atherosclerosis. When we are born, the atherosclerosis sets in. And if you're not particular about our modifiable factors, you can land up with an hypertension, primary. And this is very important that we understand that when we talk of systemic vascular syndrome, it's something like an inflammatory disorder because of which causes endothelial dysfunction, renin activation system, neurohormonal changes. So it affects your endothelium at different levels. Now, what very interesting about monitoring and picking up early and choosing early and treating these patients, what we call the subclinical types, is that it's not only about different organs. We have to understand that blood pressure is not a one number. It has got variability throughout the day. Like our biological clocks, we get up in the morning, we have a cortisol release, we come in the night, we have a melatonin release. It fluctuates throughout the day. And this is very important. When you have the fluctuating BP, it could be a function of so many modifiable factors, your sympathetic activity, your so many other modifiable factors. But as a pulmonologist, I'm telling you, the most important thing which we miss is the area which we grow. That is the 2/3 of a life is decided by our 1/3 of life, the sleep. The sleep is the most important as a pulmonologist. I'm a sleep disorder physician. If you see the hypertension guidelines, sleep apnea is one of the modifiable factors which has been found, which can prevent the subclinical types, and I've been seeing. And this is, if you read the most of the guidelines, they said the cardiovascular consequences of sleep disorder breathing is because of your snoring and choking. Snoring is an epidemic. It has to be stopped, and we are not particular about the sleep. We don't ask about the sleep quality, how good you feel, whether you get morning headaches on, whether you groggy in the day. I think as a pulmonologist, I will look into the most darkest area of the day, that is the sleep. If you ask, the very important thing, as you rightly mentioned, my fellow colleagues, that we should look for proteinuria, regular BP monitoring, early school education, modifiable factors, brain, monitoring, so many things we can do it, but a simple sleep evaluation. If you can do this, there are so many simple questionnaires we have got, which we can ask. How good you sleep, whether you snore, whether your partner is witness apneas or not. Do you choke, do you grog, you get up in the night, how good you feel, are you gaining weight? All these are a sign of an occult disease which you're missing, which is a sleep disorder breathing, and it's an umbrella term. It's moved from sleep apnea to simple snoring, and this is rampant in the society. I think one of the important things which I want to add to you, what you asked, is that please include your sleep hygiene rules, how good you sleep. We are exposed to the blue light, we are not sleeping enough, our sleep disorder is pathetic. One of the reasons the society is going very sympathetic because we are not sleeping enough. Our quality of sleep is not good. Our snoring is high. Our so many things, alcohol that affects your pharyngeal, because the pharynx is a conduit which decide your oxygenation intake to your lungs. I think as a pulmonologist, as an internist, I will focus highly on the quality and quantity of the sleep and look for the sleep disorder breathing. This is one thing I just like to add. The internists who are sitting, the physicians who are seeing patients, please also add these things in your clinical algorithm, clinical tools, rule out sleep disorder breathing.
Excellent point. I mean, I did a residency in sleep medicine. I share his views. Very simple. Do you snore? Yes, I snore. How loudly do you snore? Does it wake your partner up? Yes, she's not sleeping in the same room anymore. Well, that's great. That makes the stress go down probably. But things like that. Do you have excessive daytime sleepiness? Sleep apnea, highly undiagnosed, probably endemic in Indian population. We have central obesity, thick necks. So excellent point. That's another take-home point. Sleep apnea remains undiagnosed. Dr. Dhir, coming to you, I'll start with example. Recently, a family came to me, father came to me for a second opinion. Young man, 37 years old. Sunday, he was an advocate. Recently married, 4-year-old son. Every Sunday he plays cricket. He's coming back from playing cricket. He calls his father. He says, I'm not feeling well, main uneasy hu. He self-drives himself to AIMS emergency department, collapses right in front of the casualty. AIMS people, they did a CPR for 40 minutes. 40 minutes cardiopulmonary resuscitation. The heart comes back. Family shifts him to Apollo. They come to me, he's brain dead, clinically. So everybody worries about heart attack, heart attack, heart attack. So again, coming back to early detection, when do you think, I've always thought about asking this to a cardiologist, when do you think we should have a first ECG or a first thorough cardiac evaluation? And what is that? Is it just an ECG, or would you say it's an ECG or EKG plus an echo? Does it have to be a stress test? Can you just put some highlights again with respect to early detection of this problem?
Thanks for a beautiful question, and I would love to answer it. See, most important thing is, until and unless you assess, you cannot evaluate the problem. That we all know. At what point should we start assessing? So it is multifactorial. It cannot be just like a pristine thing and all that. It varies from family. It varies from person to person. See, we were getting angiograms for any cardiac valvular lesions. The guidelines were previously that at 40 we used to get a coronary angiography. The youngest patient whom I have done a cabbage, the coronary artery bypass grafting, all the 3 arteries were blocked. 18 years old. There was a time just, I would say, 6 weeks ago when my oldest patient whom I had done cabbage was 49. The youngest was 28. So the guidelines have shifted. Previously what we used to do is, if you have a strong family history, what I have, I would say everyone would conquer. I operated a lot of patients whose fathers and mothers I have operated. I am operating their son. Their father was operated at the age of 62. I am operating their son at 47, at 52. So we have, rather I would say, depreciated by 10 years. We are getting the aggressiveness of the disease 10 years earlier. So previously our screening was, if you have a strong family history, if you are hypertensive, your grandparents had a history of a stroke or a kidney disease, if your maternal or paternal side, anyone had any issue related to blood pressure, related to diabetes, you should evaluate yourself at the age of 30. Your first ECG and a simple baseline echo, and right now we have a screening test. See, vessels we can trace right now. So we have a thing which we call intimal medial hypertrophy. It is just like a carotid Doppler. So in that we see the thickness of the arteries. If the thickness of the artery is more, then we can say that you are at a higher risk of a cardiovascular event. That cardiovascular event could be a stroke, could be a sudden cardiac arrest, or could be a kidney damage, or could be a loss of vision of your eye. So we have to be vigilant. Most important thing, if you are normal, you don't have a family history, your father had diabetes at the age of 70, then you should start your screening process between 35 and 40. Okay. If you have a very strong family history, I would recommend right now, start at 30. गर्दन गिरने के बाद तो इलाज करने में हम लोग सब हैं. Point is, गर्दन गिरने नहीं देनी है. That is most important. It is not that we are now advanced, we treat 5%, 10% of heart function. But why do we need to reach that stage? That is most important. So screening, I would say, for hypertension, I still feel, because I'm getting because I have operated their fathers and they check that, that's why they are getting their kids for, sir, BP dekha 180, 120 hai. So point is, for hypertension, we should screen, aptly said, at 15 years. We should have a diligent, and I would say blood pressure monitoring is the most unrecognized thing, and no one pays heed to it. हमारा मेडिकल हुआ था, मैं आपको बता रहा हूँ, जब मैं मेडिकल कॉलेज में घुसा था, हमारा मेडिकल हुआ था, और मेरा स्टैंडर्ड बीपी 110/70 लिख दिया गया था. आई डोंट रिमेंबर कि मेरे मेडिकल स्कूल में एंटर करते वक्त भी मेरा जो मेडिकल हुआ था उसमें, एंड उसके बाद एमएस में मेरा मेडिकल हुआ. आई एम फ्रॉम केजीएमसी, सो एमएस में मेरा मेडिकल. मेरा बीपी की रीडिंग पल्स पहले ही 72 और बीपी 110/70 लिखा हुआ था उस चार्ट. Point is, ये नहीं होने देना है. This is the most important thing.
Thank you. Very important point. Here again, the take-home message, what Dr. Saab is saying is that the screening starts based on your individual risk. So instead of what is called individualized medicine, nowadays we should go for what works for me, what is your screening requirements might vary from that of your partner. Dr. Venkatakrishnan, I have a very common question which people ask me as a neurologist. You have a lot of blood pressure monitoring machines nowadays. Omron is there. You can take your blood pressure. Simple but kind of important question, how good are those machines as compared to going to a doctor, having a proper blood pressure instrument put on you, stethoscope, and then recording your blood pressure? Do you advise everybody should have a home blood pressure machine? It's available on Amazon, probably for a few thousand rupees. Kya aap bolte hain?
Very great question. Something that is always asked to me by the patients when they walk into my chamber. See, the thing is that digital BP monitoring machines are the future. We have to understand that putting a BP cuff in the hand, then using a stethoscope, you need two people to check that blood pressure. So digital machine, you put it on, switch on the button, you get the reading. But the problem comes when the first reading is a little different, second reading is more different, third reading is more different. So the person gets confused which of the three readings is actually accurate. So what I usually suggest to my patient is that you take three readings, maybe one after the other, and the third reading is usually accurate because by that time you are settled and the machine gives a reading in your more stable state of condition. The thing that we check in our OPD using a manometer, that is the gold standard. There is no replacement for it. So basically, if someone's blood pressure is high, then I think that whenever they come to the doctor's chamber, the BP monitoring by the doctor is the first thing that they should be doing, not just a digital reading by a staff nurse outside the room who is just checking the digital reading and noting down the BP and sending the patient inside to your chamber. You yourself should take the effort to put on a manometer and check what is the blood pressure like. But if the person has no history of hypertension, they have multiple visits, the BP is usually normal, a digital machine is equally good. So for home monitoring, digital machine is good, trust it. And if there is a lot of difference between your BP reading at home and in the hospital, sometimes it is always advisable the person should bring the machine to the hospital. It can be checked at the same time when we check from the manometer and the digital and cross-check if there is a calibration error. Because if there is a calibration error, then the machine will give a wrong reading. Otherwise, the machine reading is usually reliable.
Thank you. Dr. Bose, kind of a similar question. I thought I'll direct it to you. A lot of wearable medical devices, Apple Watch. I personally don't have much experience with the blood pressure working of that watch. But you have any other recommendations of how people can monitor their blood pressure on a more of like an ambulatory basis?
Yeah, I will answer your questions in two halves. The first of all, I think whosoever is coming to you with symptoms of hypertension, we are probably thinking of a medical checkup. I'm very particular about, because I belong to the old school, you should go very traditionally. I don't believe in this digital probably, because there's a lot of white coat hypertension comes. There's a lot of sympathetic activity associated when they come to your OPDs and all. Go with the palpatory and oscillatory methods. There should be guidelines. It should be very systematic. You should ask the patient to lie down. There's a protocol. There's one aspect. But on the other side, this is a decade of wearables and wearables. Right. The whole science is moving from hospital to the home. We are moving in the era of home care. Now, 90% of my specialty is doing at the level of home care. I'm a great proponent of home care coming. Our wearables and wearables are becoming much more sensitive and specific, especially in sleep disorder practice, we are using it. But again, it depends upon what exactly you're doing it. If you have got some amount of this hypertension as a comorbidity, or maybe you're a sleep disorder breathing, or maybe you're on some kind of cardiovascular devices which you're on, definitely these are a value addition. In fact, let me tell you one of the story. When the Apple started its first wearable, they picked up the maximum emergencies because their wearables were linked to your emergency numbers in America. They picked them early, treated them early, and they saved lives. Definitely, these wearables and nearables may not be therapeutic in the point of view, but definitely they give you a trend because as I mentioned, we are 24/7, we are under the influence of different biological hormones. The trend is very important. The fluctuations are very important. Even one of the guidelines which is say you see the fluctuation throughout the day, which is more important than the absolute reading. That talks about your biological clock, your sympathetic activity. So wearables or nearables are the need of the hour. They are very much important. But again, it has to be tailor-made. Whom you should give the wearables and nearables, not all. Now, everybody should not go for the wearables and nearables. No, it has to be doctor prescribed. It has to be tailor-made.
Thank you. Dr. Bhomik, kind of moving on towards the last part of these talks, again, coming back to wellness, because wellness is the way I think we should all be looking at. So I've always found that the target BP recommendations keep changing. Earlier on, so 120 by 80 is fine, or 130 by 80, now it's 110 by 70. These recommendations by the American Heart Association keep changing. I think the general trend is the lower the blood pressure, the better it is for organ protection. So from your point, from the kidney point of view, what do you think should be the ideal blood pressure which protects the kidney?
Thank you. If you permit me, I'll just take 2 minutes in discussing the overall perspective. He spoke very well on the sleep disorder causing hypertension. Now, hypertension is actually a part of what is called the metabolic syndrome. I want to put this here because obesity is now rampant in society. So hypertension is one of the parameters in the metabolic syndrome. And that obesity part also has to be taken care of. In the inaugural speech, one of the respected members mentioned that, BMI and better than that is the waist circumference, the waist hip ratio. In fact, the paradigm has changed now. BMI is no longer taken as diagnostic of obesity. You have to do the waist hip and waist hip ratio. So that is one of the parameters. So why I'm saying this is that in one of the recent ICMR studies, very important study, where 5 lakh people all over the country were studied from all the 4 quarters, and they found that 43% of us had mono. Now, what is mono? Mono is metabolically obese but not obese. Means they look fit and fine like me, but then if you check their BP, they check their waist hip ratio, check their blood sugar, check their HDL cholesterol, their LDL cholesterol and the urine proteins, there's something wrong. And they took 2 out of these 5, they were abnormal, they're called metabolically obese. So unfortunately, in the country now, 43% of us are metabolically obese but not obese if you look at the person. And this is more so in the rural areas, surprising. This was also mentioned in the inaugural talk. So I think there are very good takeaways from there, and we have to take hypertension in that perspective. I'll also complete, what he mentioned earlier, what are the other investigations. So I'll mention here that, apart from sleep disorder, obesity, it's very important that we also look at the electrolytes. In fact, the American guidelines do mention that when someone is diagnosed with hypertension for the first time, it is better, apart from ECG and creatinine and urine routine, you also do the electrolytes, because electrolytes also have a very important clue as to whether hypertension would be secondary or not. If the patient has some endocrine hypertension or vascular hypertension, so it's very important also to do the serum electrolytes, look for any hypokalemia, and we'll also, of course, also like to do the lipid profile, which is I think obvious. So this much workup of every hypertensive is important because, as I said, 90% would be primary hypertensives, but 10% would have obesity, sleep disorders, chronic kidney disease, or endocrine problems. Now coming to the targets. So I am a nephrologist, I'll stick to my targets. So it's good to know that there have been very good studies in this regard. And more than 10 years back, we had something called this sprint trial in which they excluded diabetics. They didn't have diabetics, but they studied whether 140 or 120, which is better. And they found that less than 120 is better for cardiovascular and overall mortality risk. That was called the sprint trial, which excluded diabetics, which is a very important subgroup population of our CKD patients. Subsequently, we had a Chinese trial just last year, which included diabetics. And there also the same findings came that if you keep a lower target of 120, that improves survival. So what I will say is that if a person doesn't have chronic kidney disease but is an hypertensive, definitely would like to target for a lower BP 110 if possible. Problem with 110 BP is that someone can suddenly have also static hypotension. One has to be careful about that, or rarely it may develop acute renal failure. So these are common complications. But so in a case-by-case basis, the targets have now been lowered, as you rightly said. Targets are now lower, even in our CKD patients. It's a very interesting trial I just read a couple of days back. In an Iranian population, they took those not patients, the normal people, 60 plus, who had pre-hypertension, or whatever you call it, between 130 to 139. And even in that group, they found that if you reduce the BP to 120, the mortality rate was better. So I would say that to protect the kidney and the heart and the brain, targeting in our scenario, I think around 120-25 would be a good
Thank you.
alternative.
I'm kind of coming to end. I have a question for Dr. Gupta, and then I'll end with Dr. Goswami. Dr. Gupta, one thing which I'm finding with Indian population is compliance with blood pressure medicine. Many people feel that 1 साल blood pressure medicine ले ली, blood pressure has been रूट से निकल गया, खत्म हो गई भी बीमारी, मैंने दवाई बंद कर दी. And then they land up with Dr. Goswami and me, stroke हुआ है, blood pressure है, हाँ, दवाई ले रहे नहीं, क्यों बंद कर दी? वो 1 साल ली थी, डॉक्टर साहब ने बोला था बंद कर ली. So, with respect to kidneys, and I'm sure with respect to the heart, you find the same thing. How do you overcome this barrier in Indian population of taking medicines? I try to explain to them that sometimes taking the medicine will ensure a longer, healthier life than not taking the medicine. So, आपका क्या experience है? And maybe you have a better way of explaining than I've been able to figure out.
या जो आप एक्चुअली मैंने पहले ही बोला कि एडिक्वेट ब्लड प्रेशर कंट्रोल सिर्फ 15% में है. सो ये जितने लोग ये बैठे हैं और बीइंग अ डॉक्टर, हमारी रिस्पॉन्सिबिलिटी है इस चीज़ को री एम्फेसाइज करने के लिए. हम सब की इन इंडियन पॉपुलेशन क्या टेंडेंसी है, सुबह दालचीनी का पानी पी लिया जी, उससे बीपी ठीक हो जाएगा. सुबह लौंग का पानी पी लिया, अजवाइन का पानी पी लिया, उससे बीपी ठीक हो जाएगा. So this is not the right way. You have to take the medicine, and one most important thing, involve yourself in some sort of exercise. आप किसी ना किसी फॉर्म में एक्सरसाइज करिए प्लीज़. Either walking, either cycling, either running, and being Indians, we have a habit of eating not Western food. Adopt Indian food. Listen to our Prime Minister, adopt millet-based diet. And with each and everything, your blood pressure will get controlled. And you can modify the dose of your medicines, but don't stop the medicines, otherwise you will end up into the complication. These are the common problems. The people stop the medicines, decrease the dose of the medicines, and they never, many people come to me after 7 years, 8 years, what the medicines have prescribed, saying, Doctor sir, यही ले रहे थे, इससे तो फिर problem हो गई है. So it is not the way. When doctor asks you, come to me, follow up properly.
Thank you. Dr. Goswami, coming to you.
May I add one thing?
Yeah, please go ahead. I'm sure you have something to say about this.
See, I tell you the example, I was just... So, there are 2 questions which come to, I have operated and all that, they stand. Doctor, BP, please said 120. So, wife called up with a panic attack. I was able to achieve the BP of between 110 and 120, and the diastolic lower one, 60. There was a panic attack. The wife called my husband, blood pressure has lowered down. You changed the medication. It has dropped to 110. Second thing, डॉक्टर साहब ये बीपी की दवाई मत लिखना आप, ये ना लाइफ लॉन्ग खानी पड़ती है.
Exactly.
So he came, he bought a new Merck GLS. He came in that, and I asked, मैंने कहा इसकी सर्विस कराने आप भेजोगे और जब वो 5000 किलोमीटर पे बुलाएगा तब आप कार की सर्विस के लिए भेजोगे कि नहीं भेजोगे, या एक बार खरीद ली तो चलता रहेगा. That was the time he understood that example. So I told them, maintenance is always cheaper than getting a repairing done. So we have to reinforce that. अगर इस डोजेज से मेंटेन करते रहेंगे तो अल्टीमेट कॉस्ट, मैंने कहा आप दवाई ले रहे हो, आप 1000 रुपए की दवाई ले रहे हो, आपके 3.5-4 लाख रुपए किसी प्रोसीजर से बच रहे हैं, तो आप फाइनेंशियल गेन कर रहे हो. they only understand this financial gain, which as doctors we are not able to reinforce. हम हमेशा ये कहते रहते हैं कि नहीं आप regular checkup के लिए. So they can spend 10,000 bucks on a saloon, on a good food, but they would not love to spend 1,000 bucks on a doctor's chamber for hypertension. We have to reinforce that. It is not about 1,000 bucks. It is not about 2,000 or 6,000. It is about that we have to bring that faith in the community. We are not here to charge. We are here to treat.
Excellent point. Dr.
One more
Goswami,
point I will just like to add.
Sure,
Just one
please,
second.
please, go ahead.
The thing is that, as I must say, hypertensions come to me a lot because as a physician, I'm the first person they come to.
Right.
So before we start any medicine, I think communication is the most important thing. If you don't communicate to the patient that your blood pressure is high, these are the complications you're likely to face in your lifestyle, in your entire lifetime. If you stop the medicine, things are going to go other way around, first thing. Second, the patient's economical condition is something we should always look at. No two patients are same. Even if they pay your rent, your fees, someone is very poor, someone has afforded that money, and someone is very rich. And unfortunately, the medication which is available is also across the brand. Some are very cheap, some are very costly. So we have to select the patient before advising the medicine whether this person can really afford this set of medicines that we are giving to them. Like Lasix is also available, furosemide, torsemide is also available, but the cost is different. So we have to decide which patient gets torsemide, which patient gets furosemide. So like that, cost is important. We have to select the patient, give the patient, tell them lifetime medicine. There is no shortcut to it. If we reinforce from our side and don't show them a path that देखते हैं, monitor करना, आगे सोचेंगे, they get it, this thing कि हो सकता कभी छूट जाए. वो हमें that escape path should not be given to the patient. Clear communication is the most important thing. Plus cost identification and telling the patient this is the likely cost, can you really afford it? Otherwise, I'll write some cheaper medicines for you or you go for generic medicines.
Right.
One thing I would like to add, sir, here. We all, as physicians, we all see there is seasonal variation in the blood pressure readings. So during winters, the blood pressure reading goes up, and during summer season, the reading goes down. So we must advise patient to monitor the blood pressure, and whenever there is low blood pressure or blood pressure is going on the lower side, what is required, we should titrate the dose of medicine, because we cannot keep the blood pressure medicine at simple standard dose. So modification is required time to time. So I always ask patient to monitor the blood pressure. I always tell patient to monitor. Whenever I start blood pressure medicine, I tell patient to monitor your blood pressure for 1 month, 2 months, and keep me sending the blood pressure reading morning, afternoon, evening, so that your blood pressure should not go down or it should not be on the higher side. So seasonal variation has an important role to play in blood pressure medicine.
Thank you. Actually, Dr. Goswami, I'm going to end with you, but very quick across the group, but starting with you, it's like, ending with wellness. Many people don't realize, especially lay people, that blood vessels are the same. If you have stroke, you likely have heart disease. If you have heart disease, you likely have stroke. They're the same blood vessels going up and down. You probably also have hypertensive retinopathy or nephropathy. So coming to protection, the brain is a beautiful organ. Frequently, it's very silent when it gets damaged. With respect to hypertension, overall protection, starting with you, any recommendations you have, blood pressure, exercise, any supplements to protect the brain from the ill effects of hypertension, and then we'll go across to the nephrologists and cardiologists and the internists.
Sir, as we all know, prevention is better than cure. So we must take efforts to prevent hypertension. So for the hypertension, if the person is having a strong family history, so the person should get his blood pressure checked regularly, 3-month or 6-month interval from early age, like 20 years, 25 years. Not only family history of hypertension. If there is a strong family history of diabetes, strong family history of cardiac disease, and strong family history of stroke, the person must check his blood pressure at home at 3 months. I'm not asking person to go to the doctor. Blood pressure machines are available for 1,000, 2,000 rupees. So they can buy the machine, keep that machine, and keep on checking the blood pressure. Anytime he found the fluctuation, the deviation from normal readings, he can go to the doctor and get it treated. So regular blood pressure checkup is most important thing, particularly if there is strong family history of blood pressure, diabetes, any cardiac problem, any stroke. So by regular checkup, we can prevent further damage to the brain or any organ of the body.
Thank you. Dr. Dheer, again, 30 seconds. Exercise, any supplements you recommend which are heart healthy, and then we'll go across to the nephrologist.
I will take 15 seconds.
Perfect, thank you.
I'll take
Because
15
everybody's
seconds.
starving probably.
Yeah. शेर से स्टार्ट कर 2-4 कदम चलने को चलना नहीं कहते जो रास्ता मंजिल तक ना पहुंचे उसे रास्ता नहीं कहते The point is मंजिल is blood pressure target 120 से नीचे regular medicines regular checkup or what I say for diet and all that if we have all the 7 colors of rainbow food in our food what we are having don't put extra salt. See, हम लोगों को I belong to Western UP. हर एक को आदत है जैन शिकंजी का वो मसाला लेके सैलेड पे वो डालना. सबसे पहली चीज दही आए, दाल आए या वो. I have a lot of friends from MP and Rajasthan. सब भुजिया वो. उस चीज को अगर हम curtail करें, एक्स्ट्रा जो हम नॉर्मल फूड डाल रहे हैं, जो घर में बन रहा है, उसके ऊपर एक्स्ट्रा सॉल्ट ना डालें. पापड़ चटनी अचार का यूजेज लिमिटेड करें और जो मैंने कलर्स बढ़ाए हैं रेनबो के 6 to 8 hours sleep is most important. Regular exercise 45 minutes 5 times a week. आपकी एक्सरसाइज कुछ भी हो सकती है. आप दौड़ना चाहते हैं आप दौड़ें, आप जिम जाना चाहते हैं आप जिम जाने. चूज योर डेवल बट डू इट डिलीजेंटली. आपकी हाइपरटेंसिव की डोज आधी हो जाएगी, आपके रिस्क 50% रिड्यूस हो जाएंगे. 100% सिर्फ गॉड कहता है बट आपके रिस्क मोर देन 50% रिड्यूस हो जाएंगे. थैंक यू.
Thank you. Dr. Gupta, Dr. Mohammed, do you have anything you want to add with respect to renal protection, supplements, anything which you want to add more for us?
See, from renal protection, I think most important is maintaining a target BP, and I always tell my patients that those machines may not be that accurate, but it's good to keep their own record at home, subject to its limitations. You see, the ideal thing is to do what is called as the ambulatory BP monitoring, which you do in selected patients. Can't be done in all patients. That is the ideal and the best. But short of that, I think checking BP, blood pressures at home, and our patients need regular monitoring. They need to come every 3 months so that we can check not only their BP, but their serum creatinine and their urinary proteins. Best, of course, is the albumin-creatinine ratio, which is now done at most places, but short of that, at least a protein-creatinine ratio. I think that would go a long way in
Thank you so much.
There is a one concept of DASH diet, dietary approach to stop hypertension. That contains usually the diet should be rich in salads, fruits, low salt, red meat should be avoided. So we can accept that concept, DASH diet, and we can decrease the risk factor of
Thank you.
I just mention here one thing, yes, DASH is fine. I'm a Bengali, that's why I'm speaking from that perspective. We eat a lot of fish. The Mediterranean diet is also very good, and that includes a lot of olive oils and the sea fish and the other things along with the DASH diet. So
Just
I think
one point.
that can be given those who accept that diet.
We have discussed everything here. Just one thing we have missed out, good sleep. And second thing, that's sleep apnea, but good sleep.
Right.
Time fixation of sleeping, if possible.
Right.
Screen time fixation at night, that after this time I will not see screen.
Right.
And smoking and alcohol.
Very
These
important.
things have to be taken into consideration if you need a good lifestyle. We should not forget the fact that good sleep helps in hypertension management. It is not a medicine, but it definitely helps in bringing down the blood pressure. So sleep fixation is very important, the timing and the quality of sleep.
That's excellent. I'll end with Dr. Bose because you raised a very good point, and I want to end with that because if hypertension is the #1 risk factor for heart disease and stroke, probably smoking is right up there. He's a pulmonologist. I see in India there's a lot of smoking. At least in New York nowadays, you don't find people smoking. You don't have any place to smoke. All parks you cannot smoke. Any pubs you can't smoke. Any restaurant you cannot smoke. The only place you can smoke in New York is now in your own home. So you obviously see a lot of smoking. Where is India heading with this smoking and vaping, all those things which are now coming here?
You know, before answering question, I just continue what they said with a 15 seconds tagline on hypertension. But definitely, I fully agree. Hypertension, the most important thing in today's world is a non-pharmacological approach in hypertension. And it's, when we talk of non-pharmacology, it's not only about the food and the exercise, it's a holistic harmony. It's a balance which you create in your autonomic nervous system. What suits you the best? The mindfulness is very important. The relaxation techniques, the yoga club together, I think you should have a very tailor-made. So always I said, instead of adding life to years, which is aging, you should add years to life. So that's, you should grow with the time, and that's why it's very appropriate in this forum that it should be a journey from illness to wellness, and wellness is a holistic harmony. Now coming to your question, is that smoking? Yes, smoking is bad. Now we have different genotypes and phenotypes of smoking. We have smoking, even they say that even a pregnant mother is smoking. The generation which comes is in high risk for COPD. There are different genotype varieties. Smoking is absolutely no-no. And this creates a kind of a systemic inflammatory system. Even if you're smoking 1 cigarette, this creates a cascading effect. And this is the one serious modifiable factor which can change the scenario of any kind of lifestyle diseases. To talk about it, it's very important that the smoking in all forms, I'm not talking whether it's smokeless form, and this has to be prevented. And we need very serious, and we don't talk enough in our clinical practice in OPD, are you smoking or not? Do you want to really quit smoking or not? That's very important. Since you raised this topic, I think we are very particular about it, because this is one single modifiable factor which can really help you to maintain a good hypertension.
Well, thank you so much. And I think we'll end here. I just want to thank all our esteemed panelists. We had I hope you feel we had a great exchange of ideas. You learned something. And again, thank you, everybody. Thank you for sharing your viewpoints. Bye-bye.
Thank you.
Thank you very much for a very detailed and informative session. Please come together for a group photograph. Ladies and gentlemen, let's once again give it up for all our learned speakers. Thank you very much for sharing your valuable and expert insights with us. Thank you for your time and for joining us for the session. With this, if you have any questions, you can also connect with our speakers offline during lunch. Ladies and gentlemen, with this, we conclude today's conference. We thank you all for your participation and support, and we now request you to please proceed for lunch. We wish you a great day ahead. Thank you. Thank you so much.